Good morning. Kim Eagle here for the GenTAC Alliance. Thanks for joining us this morning. We'll be starting our morning session here in just about 3 or 4 minutes. So stand by, get a cup of coffee, and we will launch this thing this morning. Good morning, everybody. Kim Eagle here. We're going to start in just 1 minute. So any last minute coffee runs, and then we'll begin. Good morning. I hope all of you are well. My name is Kim Eagle. I want to welcome you to the 6th GenTAC Summit. It's hard to believe that we've been working together for more than 14 years. This is our second live session. And I hope that all of you had a chance to visit our Hoover site and see the free addresses. Also, the amazing presentations by 5 wonderful patients who participated in our summit. Christy Poseval, Lisa Mawson, Steve Markman was wonderful, Dan Brown, Reed Piritz also participated. Really appreciate their testimonials, and I really urge you to go in there and listen to their videos. They're wonderful. Also, on Thursday night, we honored 3 people that we felt were critical to the creation of the GenTAC registry, its evolution, and now it's joining the Marfan Foundation. Esther Tolomai from the NHLBI, Patrice Desvitsky-Nickens, and Reed Piritz, who, as you remember, was the first lead for a trial in Marfan syndrome and had created a patient and family group around Marfan syndrome that ultimately evolved to become the Marfan Foundation. So we honored those 3 people on Thursday night, and we're sending them a glass flame that indicates that their flame for science and collaborative science is deeply honored by our community during the 6 scientific sessions. I want to thank particularly Joe Grima and Marion Hoffman-Bowman from the U of M, who are co-directors of the summit. And we had a summit planning committee that helped us create this meeting. I also want to thank members of the foundation who were so critical in helping us create the meeting and now operationalize the meeting. Bruno DeSalva, Kelly Koplish, Michael Weimer, Ellen Michelli, Helen Baruch, and of course, Joe Grima. Dr. Joe Grima has been absolutely critical to this. We're going to have a very interesting session, I think, this morning. I want to just give you a very brief state of the Alliance this morning. So if I could have the next slide. So beginning October 1st, the GenTAC Alliance moved from its prior home, which was with NHLBI, and its operational partner was an entity called Social Solutions Incorporated. We were delighted when the CEO, Michael Weimer, and the board of the Marfan Foundation offered to have the GenTAC Alliance move into the foundation as one of its divisions. And it joins the Asker EDS and Lois Dietz and other groups that are coming into this wonderful umbrella. And on behalf of all of the Alliance members, we couldn't be happier that this transition has occurred and that we'll now be working deeply with the foundation and all of its partners around the world. I want to thank the National Heart, Lung, and Blood Institute and the other institutes that helped create the GenTAC effort. That was massive. And of course, in these last 3 years, the NHLBI supported the formation of the Alliance. And that was because the institutes felt that the momentum we had gained in research, in science, education, and pushing care, and I think importantly, the relationships that we'd forged together in science were important and should be preserved, and we should try to find a way to continue. And in a way, this is one of the few entities I know of where we bring together patients, surgeons, clinicians, scientists together on a regular basis to discuss the state of aortic care and how to improve it. And of course, the science rules. Right now, the Alliance currently has 5 working groups that continue to function. The Basic and Translational Science Group is led by Diana Milowitz and Simon Body. The Patients, Families, and Clinicians Working Group is led by Alan Braverman and Eva Klein-Rogers. The Clinical Science Working Group has been wonderfully led by Mary Roman and Shireen Shalub. Biospecimens and Databases by Siddharth Prakash and Cheryl Maslin. And the Business Plan Working Group has been shepherded by Mike Weimer and Joe Caselli. All of those working groups are active. They've moved into the foundation now. And I think each of them will go through a period of reflection and we'll have a reset of exactly where we want to go in the next few years. But I would like to say to you, the GenTAC Alliance is alive and well. The registry we created has almost 4,000 patients with wonderful biologic samples, clinical information, images. That continues to be a field that we can harvest for research. But more importantly, I think through the working groups, we've seen the development of new initiatives that will really forge a future that's exciting, pushing the boundaries for care, science, and education. And we'll reimagine where we want to go. And we welcome all of your input and thoughts and ideas, criticisms, whatever you might bring to try to forge a future that really is impactful in this space. So this is a brief review for you from me about the state of the Alliance. I couldn't be happier to have a chance to help be a participant in the Alliance, to help lead it into new fields that hopefully will be very, very productive. So let me then move from my opening statements to the first session this morning. I'm very delighted to introduce Dr. Siddharth Prakash. He's going to be moderating session 1, which is on non-Marfan familial thoracic and early onset aortic conditions. Siddharth?
Thanks, Kim. I'm delighted to moderate this session on the current status of our knowledge of thoracic aortic disease. I'd like to introduce the first speaker in our session. Now, each of these speakers will be presenting take-home points from their video that they had recorded of a talk that is available on the website. After they present their points summarizing their talks, there will be a 5-minute question and answer session, and we will include some questions that have been posted on the app. So our first speaker is Dr. Diana Milowitz. She is the President George H.W. Bush Chair of Cardiovascular Medicine at the University of Texas Health Science Center at Houston McGovern Medical School. And she will speak to us about familial genetic aortopathies.
Good morning, everybody. Thank you. Thank you for the invitation to talk. I'm going to be giving you an update on the current status of genes for heritable thoracic aortic disease. Over here on the slide is the list of current genes that have been proposed as triggering heritable thoracic aortic disease. The ones in black are those that have been validated by a ClinGen platform to be disease-causing. That paper was published over a year ago, and I think we need to update that list because a number of these have emerged as with further data confirming that they are disease-causing. I've grouped them into different functions of the corresponding protein. The first group is proteins involved in the extracellular matrix. The next group are genes involved in canonical TGF-beta signaling. And down here we have a number of genes that are involved in smooth muscle contractile function. And then finally down here we have two newly identified genes that are involved in ion channels. So if I'm looking at these genes, we can start proposing underlying pathways that cause thoracic aortic disease. So if you look at the genes involved in the extracellular matrix and smooth muscle cell contraction, these genes are involved in a structure that's in the aortic wall called the elastin contractile unit. This is where extensions from the elastin fiber come down obliquely to link up to focal adhesions or dense plaques containing integrin receptors on the cell surface of the smooth muscle cells. They then link up to contractile units within the smooth muscle cell. So this unit is being disrupted by many of these proteins by mutations in many of the genes encoding these extracellular matrix proteins, and by genes encoding the smooth muscle cell contractile function. And pretty much they're predicted to lead to the cell not properly sensing biomechanical forces on the aorta. So we're proposing that the genes that trigger thoracic aortic disease disrupt this mechanosensing by the smooth muscle cells in the aortic wall. They sense something is wrong and they start upregulating repair pathways like TGF-beta signaling, angiotensin signaling, etc. And that's ultimately what leads to thoracic aortic disease. The nice thing about this model is that the major environmental insult, if you will, that triggers thoracic aortic disease is hypertension, and that would also alter the forces across these units by increasing the pressure on the units and perhaps trigger the same pathways. And then down here in this group here, we have all the genes for TGF-beta signaling. And these genes disrupt the canonical TGF-beta signaling pathway. And uniformly, the mutations in these genes are predicted to lead to loss of TGF-beta signaling. Therefore, these data suggest that a primary driver of thoracic aortic disease is that loss of canonical TGF-beta signaling. Now, talks by Dr. Dichek and Ramirez later this morning will go into more details on TGF-beta signaling and what role we currently feel that the current data on what this role plays, the signaling pathway plays in thoracic aortic disease. A novel gene that we identified actually is involved in TGF-beta signaling, but instead of acting on the canonical signaling pathway, it dysregulates the non-canonical signaling pathway over here and drives phosphorylation of P38 and very dramatic changes in the phenotype of the smooth muscle cell. So be looking for that paper shortly. And then in the last few minutes, I just want to talk about these channel genes. HCN4, the data for that gene is published. It's a gene that was already known to cause bradycardia and left ventricular non-compaction syndrome. And our group and others have determined that there's a few variants within the gene that also cause aortic disease. More recently, we pulled out another ion channel gene, a potassium channel gene, KCNA5. This is a gene that's already been identified to cause atrial fibrillation. The gene is specifically expressed in the aorta and other arteries, and then in the atria. So it only is expressed in 2 locations in tissues. And it's, like I said already, it's been shown to cause AFib. We pulled out this gene as a putative gene because we found recurrent rare variants in multiple patients with thoracic aortic disease that were not in any of the exome databases, and went on to pull out a number of variants, and where they're located on this potassium channel are shown here. The variants that we've identified are in red. The variants for AFib are in blue. And you can see there's some overlap in terms of the variants that cause AFib and those that we've identified in thoracic aortic disease patients. In our cohort, about 1/3 of the patients had AFib, so there was overlap in phenotype also. And then we went on to show that these variants that we identified in our patients with heritable thoracic aortic disease also disrupted the function of the potassium channel. So this is moderate data that this gene is causative for thoracic aortic disease, but it still needs additional data before it can be used in a clinical setting. So thank you very much.
Thanks, Diana. We have some questions posted on the website. One of them is, a few years ago, you reported that HTAT accounts for 20% of thoracic aortic disease. With the increasing number of genetic mutations identified, has this percentage changed?
So that percentage was determined by family history, and it has not changed based on the number of genes that we and others have identified. We know from our cohort of patients that we still have not identified the majority of genes that cause heritable thoracic aortic disease. So within within a typical clinic, if you take patients with a family history or features of Marfan's or Loeys-Dietz and run the current panel of genes, run all of these genes, that you will identify a causative gene somewhere between maybe 25 to 30%. So we really have a lot more genes to identify. And it is complicated by the fact that there is so much genetic heterogeneity. Some of these genes, like PRKG1, there's just one variant in that gene that's been shown to cause disease. And yes, we've identified up to 10 families with that particular variant worldwide, but it's still an extremely rare cause of thoracic aortic disease. So we've got a ways to go.
There were 2 questions about the potassium channel genes. I think that intrigues people because it seems relatively unexpected. So were you surprised about the potassium channel? And what do you think the potential mechanism might be involved in the thoracic aortic disease?
So I wasn't surprised. I expected to see mutations in potassium channels because smooth muscle contraction is dependent on functional potassium channels. So it wasn't a surprise at all. The other place that I really expect to find mutations is these elastic fibers come down at the tip. They're connected to microfibrils, which the major protein is in those microfibrils is fibrillin 1, encoded by the FBN1 gene, but they link up to integrin receptors. And that's the other area that I have expected to find mutation, and we've just not identified mutations in integrin receptors. It may be that they're just too critical in terms of human development and so on for them to show up in an adult onset disease.
I think that does it for our questions. Are there, and from the audience so far, are there any questions from our panelists? All right.
Darth,
Yes.
it's Kim. Diana, you talked about a study during your plenary address. It was sort of a deep dive into a database linked to aortic dilation. I think it examined 100 genes, came out with 4 that were potentially at least linked to aortic size. And I guess my question to you is that as we move into a much bigger data possibility with artificial intelligence, how much do you think we'll find things that matter versus mathematical errors because we're sort of dredging this large enterprise?
So that study, there were 2 groups that actually took the data from the UK Biobank and all their imaging data, and they did genome-wide association studies to identify genes associated with aortic size. So they identified between the 2 groups over 100 genes. I think it was about 60 or 70 that overlap between the 2 studies. And then there were unique genes identified in both of the studies that didn't overlap, which to me doesn't make a lot of sense because they were using the same data. So it's interesting that they did get some differences. These are genes that harbor common variants that triggered disease. And the only HTAD genes they pulled out from that study was fibrillin 1, but we had published that as a GWAS hit over 10 years ago. So it was already known that fibrillin 1 contained common variants that predispose to thoracic aortic disease. And then they pulled out a new gene, TBS4, I believe, that has just been recently identified but not confirmed. THSD4, sorry, it's on the list of extracellular matrix genes. But they didn't pull out the rest of these genes. So when we went back to look at all our families, unsolved families with heritable thoracic aortic disease, we actually did not find much data supporting that any of these genes they identified predicting aortic size in the general population also were genes for heritable thoracic aortic disease. We have 4 where we have minimal data, and we'll be submitting that as a short paper. But other than that, we just didn't have data to support the other 100+ genes that were identified through those studies.
Thank you, Diana. Obviously, that type of research just requires intense validation to make sure that we're not getting mathematical accidents. Let me just say that as a population scientist, I get such excitement just watching you and your teams go about your work. It's really exhilarating to watch a real deep thinker take on this area, and I really admire you greatly.
Thank you, Kim. I appreciate that. And we are going to we've already moved into machine learning. And as you said, the details become very important at that point in terms of matching your cases and controls and other issues. So we'll keep you posted on our progress, but thank you.
Great. Well, with that, we'll move to our second speaker. This is Dr. Bo Yang, who will talk about the current status of genetic testing for acute aortic dissection. Bo?
Okay. Hi, good morning, everyone. Yeah, thanks for the invitation for the presentation. I just finished a acute type A dissection last night, and I thought I couldn't make it, but I was able to make it. That's pretty good. And Yeah. And my title is the current status of genetic testing in the aortic, actually is acute aortic dissection. And so for the aortic dissection is been taken care by most cardiac surgeons, type A and type B, and sometimes vascular surgeons, sometimes cardiologists. And when we take care of the patient, do operation, save the patient, the medical management, so on and so forth. We get the patient out of the hospital, and whenever I really thought is any genetic background of the patient we should test, which do we need to do any clinical genetic testing? And I don't think many of us are doing that. So what we did is at the University of Michigan, we have a very high volume of aortic dissection, and we collected the DNAs of all the patients. And we also have a robust control database of DNAs. And we did a whole genome sequencing collaborating with Kristen Wheeler and Diana Milowitz, who just spoke. It's very interesting. We found out the pathogenic variants, they are listed in Diana's presentation, and it's a lot more common in the patient with aortic dissection. It's about 10%. In our cohorts, by 11%. And we found out in the patient with the pathogenic variants, they are always young. That's younger than 50 years old. They have sometimes they have strong family history, and they don't have hypertension. So those patients, we should recommend a clinical genetic test to study if they have any pathogenic variants or not. If the patient has, the whole family should be screened. And if we find family members have those pathogenic genetic variants, they should be watched very closely, maybe do a prophylactic operation based on their mutations or genetic variants. And then we follow those patients. It's about, in our cohort, we have 60 patients who did the sequencing, and then we identified 34 as had genetic and pathogenic genetic variants. And then we matched them with another close to 100 just benign or normal variants. So we retrospectively followed them for about 15, 20 years. I want to see what happened to them after the initial dissection and initial operation. We found out all these patients, if they didn't have their aortic root replaced during a type A dissection repair, down the road, 80 to 90% of they have reoperation of aortic root replacement. So we recommend those patients, if we know they have pathogenic genetic variants or suspect that they have, and when we see those patients and when we do an operation like type A dissection repair, we should strongly consider to replace the aortic root, either biospinal roots or with the ventral procedure. Yeah, that's the last two studies we conducted in the genetic test of the patient with the aortic dissection. I'm happy to take questions.
So, Bo, let me thank you for your presentation. Also, thank you for taking care of our patients with dissection, even in the middle of the night before you have to present. This is just amazing to me that you can do all that you do. Let me ask you, the study we did looking at dissections who were young, I think about half of them had FBN1. How many of those were known to be Marfan versus patients who were not known to have the phenotype until they had their dissection? Do you recall?
Oh yeah, so in the 34 patients with pathogenic variants, about 70% actually is Marfan's patients. and the rest are SMART3, TGF-beta receptor 1, and collagen mutation and the LOX mutation. So FIMBR1 actually is the most common mutation in this pathogenic group. The question for you is, during the dissection, how often do we know they have genetic variants, pathogenic genetic variants or not? That's very difficult. Sometimes we know this patient suspected, or they look like morphanoid body habitus. And after surgery, most time patients, we discuss with the patient if they're young. So do you have family history? You have hypertension? If they don't have those issues, then we will send for a clinical genetic testing, and the further identify if they have the pathogenic genetic variants or not.
Great. We have one question from the audience. It says, based on these data, did your group decide not to test post-dissection patients who are older than 50 years without a family history, or those who have hypertension?
That's a great question. That lady I did last night she's 71. She has a thick ventricle, and her aorta, the root actually is normal size, and ASIN is dissected about 5 to 5.5. I think most likely this lady is from hypertension, and I don't think because in our population, 90% patients in this category, we couldn't identify the pathogenic variants, and she doesn't have any family history. So I would not refer her for a clinical genetic test. Based on current genetic test, we have 24 to 26 variants we're checking. I don't think we're going to get a positive finding.
Any other questions from our audience or panelists?
I have 3 slides. I don't know why this is the last summary slide. Anyway, go ahead.
There is another question in the Q&A. It's by Marianne Hoffman-Bowman. Patients with pathogenic mutation had less frequent HTN, but if they had it, it was the strongest for RF for dissection, or 5.5.
I think that was in response to Kim's question about whether or not there were specific clinical indicators of patients with pathogenic mutations.
Okay.
So I think most of them did not have hypertension. And again, the presence of hypertension invariably, particularly in young patients, can confound some of our evidence for whether or not a pathogenic mutation may be present.
So let me go back then to Bo and ask the question again. If we have a young dissection, say 50 years or less, no family history, no clear risk factors for hypertension, like hypertension, cocaine, smoking, and there's no evidence of having a phenotype that you would suggest a syndrome, should we be genetic testing those people? And if so, what is the yield?
Yeah, a patient younger than 50, no family history, and no history of hypertension.
Yes.
Am I understand correctly?
Yeah, young dissection, you don't know why.
Oh, okay. Yeah, I don't know the percentage of the yield of genetic testing, but for young patients, we would recommend a genetic test, and especially no hypertension, could be just sporadic mutation, and especially now the genetic test, I think, is covered by some insurance, and the patient doesn't have to pay for the genetic test. I would recommend.
Siddharth and Diana, do you test those people?
Certainly, we would test most young patients who had no apparent underlying risk factors in our practice. I know Diana also frequently enrolls those patients in our research protocols who have negative genetic panels. So we do actively explore most of them.
Yeah, I do too.
So our recommendations currently are to test people that have syndromic features and thoracic aortic disease, a family history of the disease, and then also individuals under the age of 55. And that's because when we did whole exome sequencing on a cohort of patients that had no family history and no syndromic features, we still found that 10% of those people had a pathogenic variant, and the major gene was FBN1, interestingly enough, and that 5% of them had a pathogenic variant in FBN1. And I think you had similar findings, right, Bo?
Yeah, it's pretty similar. Yeah, good to see you, Dana.
Nice to see you too. Glad you could join us. Glad the surgery went well.
Yeah, the lady did well.
Great.
Yes, we have several comments that genetic testing is probably indicated for that population from our attendees. And so I think we have broad consensus at least among the panelists and presenters that would be indicated. Any other questions for Bo? If not, we'll move on to our next speaker. Dr. Joe Coselli from Baylor College of Medicine is going to talk to us about surgical cut points in familial aortopathy.
Kim, Siddharth, good morning, everyone. Just, can you hear me?
Yes.
Okay, just a side note before I start talking about this, that Bo's slide, he had less than 50 years. You heard Diane, she spoke about up to 55 years. And we're beginning to think in terms of, with modern medicine, as it were, these days, that maybe that age ought to be moved up to 60. Maybe 50 is too low. With regards to the cutoff in familial aortopathy, until we have the ability to specifically identify the integrity of a given individual's aorta, what we've been able to use over the last number of decades is still based on size. And the size point or cut point in which the natural history of the disease becomes problematic from a statistical standpoint for a given patient, using information based on larger data banks, such as the Yale. We then overlap that with what we know about the specific risk factors within the various syndromes, and there's no way I can sit here and break all this down into the myriad of genes that Dr. Milowitz pointed out. But it was set in 1997 in general by a very, very nice paper by Cody at about 6 centimeters. And then more recently, things have drifted down towards 5.5 to 5.25, but then again, varying for these bicuspid Marfan, Loeys-Dietz, small stature, which is Turner syndrome, for instance. And then, as I'll mention here in a minute, we need some flexibility based on the particular situation for the risk of surgery. But the whole idea is in the non-symptomatic person to avoid being in Bo's operating room in the middle of the night, but to have these things treated in a way that can be prevented. I think also you have to overlap to keep in mind that the risk of surgery for these individuals is a little different than a simple aortic valve replacement. If you look at the STS database, the risk of aortic valve replacement should be around 2 to 2.5%. But as mentioned, these patients shouldn't necessarily have, truly on an elective basis, a simple aortic valve replacement. But the overwhelming majority are going to need root operations, a valve sparing operation of the David type, or some modification of that, or one of the modifications of the classic Bentel operation. For bicuspid valve, the guidelines for the European as well as the American Heart and the American College of Cardiology have focused recently on about 5.5 centimeters in the usual patient. asymptomatic individual. Keep in mind that there's some debate right now over whether or not in the bicuspid valve, whether the integrity of the aortic wall is that much different really than a tricuspid valve. But in the bicuspid valve, you have to break it down into the morphology of the aortopathy, whether it's a root, tubular, or simple ascending, leaving the root of more normal size. And it's probable that those are different with regards to their natural history, with the root morphology being the ones at the greatest risk. I'll take a minute here and say that on a decision-making situation in patients who are asymptomatic, and you're following these patients and trying to decide on this cutoff, most of the guidelines build in a set of risk factors, which include such things as hypertension, a family history of dissection, rapid growth, desire for pregnancy, etc. In all of these cases, in those situations, the cutoff point drops down at least a half a centimeter and sometimes a full centimeter. There's another situation in which size makes a difference, but it's at a different level. That, for instance, is an example of a patient who needs to have an aortic valve replacement based on the pathology specifically of the aortic valve and whether or not to leave the ascending aorta behind. And in those cases, for instance, in bicuspid valve, for many of us, that lowers down not to 5, 4.5, but down to even 4 centimeters. For Marfan syndrome, again, it runs around, the guidelines run around 4.5 to 5 centimeters. Again, around 4 for patients with aortic valve replacement need, but in general, they should, most of them get, with very rare exception, a composite valve replacement. Loeys-Dietz syndrome is a much more aggressive aortopathy, and so the size is 4 to 4.5 centimeters. Small stature, which would include patients like Turner syndrome, have a decision based on an indexed aortic size, based on height and body size. And in my presentation, I give some of these formulas that we usually use. I also think that we have to build into our decision-making process, as do most of the guidelines, the surgeon and the surgical facility in which the operation is being done, because that overlies the risk of operation in a particular situation. So what we mean by that is programs such as Michigan, ourselves, Dr. Milowitz Group, et cetera, there's many of them now who have a fairly sizable volume and experience in this kind of surgery. And the guidelines allow for a smaller diameter to be managed on an elective basis in those situations where the expected risk of surgery is on the lower end or even below the lower end of the range that's described in such things as the STS database. So I think I'll stop there.
Thank you. Unfortunately, we're running a little behind and we need to move on to the next talk. I would remind everyone that they can post questions to the Whova app and our speakers will respond to them as they come in. Thank you. Our next speaker is Dr. Alan Braverman from Washington University School of Medicine. And Alan will talk to us about how to manage patients and families, addressing lifestyle and fears. Alan?
Good morning, Siddharth. Good morning. Good morning, Kim. Thank you for the invitation to speak. My task is to discuss the care of patients and families and addressing lifestyle and fears. And yesterday I saw a young man, 40 years old, in the clinic for initial evaluation of Marfan syndrome. He had had a valve-sparing root replacement in 2008 and was living life successfully in North Carolina, when a year ago he had an acute type B dissection complicated by malperfusion and renal failure, visceral ischemia, and had an emergency endovascular repair, which was successful and saved his life. He moved to Columbia, Missouri, and then came to see me yesterday for evaluation. And the last year of his life, he's been devastated. and has suffered from really from post-traumatic stress disorder, has not been able to live successfully because of concerns. And I use his case to highlight this issue, which is so common. And I asked him, what is the main concern you have? And actually his main concern was, since he had a replacement of the aorta proximally and now endograft distally, what in the world is going to stop that little segment of the aorta, the arch, from doing the same thing? He was living his life worried that that was the next catastrophe, and he wasn't able to move forward. So managing individuals who have heritable disorders, like we're discussing here, or have had an aortic dissection or at risk for dissection, really encompasses so many aspects of both the medical care, the surgical care you've just heard about, including what diagnosis is present. Do we understand the gene? It's very important to recognize that when possible, or to evaluate each family member to see who's at risk by imaging, and then follow up if imaging's normal and we don't have a gene. What medicines are appropriate, how to dose them at the highest doses tolerable, what combinations are appropriate, informing our patients about their aortic imaging, how often to do that, what agents are successful or necessary, when is it not necessary to use dye, and importantly, like in the person I saw yesterday, how to be physically active, what's safe and low risk. In women, contraception is important to prevent unwanted pregnancy, or how to plan a successful pregnancy and labor and delivery. And as Dr. Caselli mentioned, all the caveats with going forward with shared decision for timely surgery, which is so variable. And those hard cutoffs, as Joe mentioned, are not so hard for most individuals. And the care that everyone on this call and webinar provides includes making people have a good quality of life. Because of the successes in medical, genetic, and surgical therapy, we anticipate people with the conditions that we serve will live a long life. And so I like to use that sort of optimism, realistic optimism, in telling them, I expect you to live a long life. And then how do we improve daily life and quality of life? What factors are present? And really spend time and effort in exploring these things which improve people's quality of life, their pain, their fatigue from mental health or medicines, their physical activity, the importance of sex, gainful employment, or disability when appropriate, and advocating for that. And I do think, and am happy to be part of the GenTAC Alliance and all the partners from the foundation and all the collaborators on this call, that we can study these aspects in a formal way and improve the physical activity, exercise, rehabilitation, and really the quality of life. So the long life that people will live with these conditions will be even higher quality. So I'll stop there and entertain any questions.
Thanks, Alan. Does anyone on our panel have questions? I don't see any questions have come in from our from the app yet. If not, I will ask a question. One of my most frequent questions from our from dissection survivors in particular is about sexual activity. And in many cases, they're asking, men ask about whether or not they can take an ED drug like Cialis, and how quickly after recovery they can engage in sexual intercourse. What do you counsel your patients about that?
Well, that's a very important topic, and we share a decision with the person involved and the partner involved about basic, the physiology of sex is that it's really a low to moderate aerobic activity for most. We talk about exercise in general and how sexual relations is a type of exercise. And so we really just emphasize the safety of it. I think sex is considered a low risk event for individuals. So usually after the sternum heals, after type A surgery, or after some period of 4 to 8 weeks after a type B dissection or after a type A dissection heals, then just like cardiac rehab or routine physical activity, we think it's safe to go forward. Many patients ask me about using ED medicines like sildenafil and others. And I know there have been some reports of concerns about those agents. I don't know of any sort of randomized or controlled information that would indicate harm. I personally think that if the effort of sexual relations is made easier by that type of preparation, then probably the physical activity itself is also made less intense. So I do not have a problem with prescribing such a medication for my patients.
Thank you very much, Alan. Unfortunately, we do have more questions, but we need to move on due to time constraints. And again, the questions are available on the app. Our next speaker will be Dr. Shane Morris of Texas Children's Hospital and Baylor College of Medicine. She will talk to us about imaging biomarkers. Are we there yet? Shane?
Hi, thank you guys so much. Good morning. It's fun to be here and fun to hear everyone's summaries. I really enjoyed looking at all the talks over the last couple of days. So my task was to talk about imaging biomarkers. So these are ways we can look at our echo or MRI or CT and try to figure out what the course would be for patients. I know we all look at these complex images and sort of say, well, what can we find to tell us what's going to happen? Like Dr. Caselli mentioned, we've been using size for a really long time, and that's just not ideal and is not the most helpful. Certainly it's probably our best predictor, but really varies widely, and it'd be better to find markers that show tissue integrity, like he mentioned. And so we talked generally, there's a lot of biomarkers that have potential, but nothing really has excellent discrimination right now. We discussed that there's kind of two kinds of biomarkers. There are ones that I call static and ones that are dynamic. So static would be something like bicuspid valve. It's not really a biomarker, but it's something that you have, if you have it on top of a genetic aortic syndrome, certainly the risk seems to be increased, at least in Loeys-Dietz. But that is there your whole life, so you can't follow it to predict dissection. Another biomarker, tortuosity, arterial tortuosity, which I really like to follow, really seems like it's not that dynamic of a biomarker either. It seems to be present from birth and slowly improves over time. And certainly people with higher tortuosity have higher risk of dissection at some point in their life and at an earlier age, but it's not something that changes much over time. And so some of the things that do seem to change over time are aortic strain. We talked about the difference between circumferential and longitudinal aortic strain, and there's been some conflicting reports looking at those by MRI. Now that is a dynamic biomarker. It seems to change over time. It reflects stiffening of the aorta, and if you're stiffer of the aorta, you're more likely to have more aortic growth. But really, those have really been studied in papers. The circumferential aortic strain was studied in a young population, just looking at who got surgery. Longitudinal aortic strain was recently published by the Spanish group and was associated with dissection, but the discrimination isn't quite there yet, and we need to keep looking at it. And sort of as we always come to, although I wish it was easier, management decision-making is really complex in these patients. And I think it's going to take a combination of taking your baseline static risk factors like your genotype and your Z-score, which doesn't change much over time, and possibly tortuosity, and then adding in the dynamic biomarkers like aortic size, strain, and possibly other risk factors that we're going to discover. Although we got to keep looking, because I do think that there's a lot of information both in the imaging data we get and the laboratory data we get, but we're just not quite there yet to predict dissection. The ideal world would be that we operate the day before someone dissects, but we're not quite there.
Thanks, Shane. So do we have any questions from our panelists? I'm waiting while we wait for the app to refresh.
Shane, this is Kim. Thank you for this magnificent work. What will it take, do you think, for particularly the tortuosity data to become part of our decision making?
Well, I think, I think tortuosity data is pretty easy to get, especially in the populations we know it's relevant, which is Marfan syndrome and Loeys-Dietz. I think probably in all the TGF-beta disorders it's relevant, and we just are submitting a paper soon that it looks like it's relevant in vascular Ehlers-Danlos syndrome. And I mean, we know on average it takes 17 years for something to become actionable in medicine, right? Once you discover it. So I don't know, but I think it could be incorporated now as a higher risk. I think we need probably more papers that have cutoffs, clinical cutoffs. Clinicians like cutoffs and say, if it's above this number, your risk is higher. And so we're working on that now, so people have a better tool where they can just say, measure it, put it into this formula, and that makes you high risk or low risk. So I think I think it's both making easy tools for clinicians to use and then demonstrate its efficacy, which we need to do with strain as well, and other tools.
Thank you. You're right. Simple population scientists like me need cutoffs.
Right. Well, I'm a population scientist too, so I get you. When in clinic, even when I look at high tortuosity, I'm like, ooh, I think I need to send them earlier. But do they make the cutoff? So we still are working on it.
Do you think we should move to aortic tortuosity instead?
So I know there's been a couple of groups that look at aortic tortuosity, but I actually think in our analyses, it's a lot less sensitive. You know, when vessels are lengthening, the smaller vessels seem to lengthen faster than the large vessels. And so it's hard because aortic tortuosity both reflects the genotype. You know, we know that people like with Loeys-Dietz and Marfan syndrome have longer aortas, but a lot of that is from birth. So it's less, you know, there's less variation because it's one big vessel with one curve. And so it seems to be, it certainly we can keep looking at it, but it's also less sensitive to, those numbers are a little harder to discriminate. There's a lot more overlap because there's not such extreme variance between people who don't have disease and do have disease, or high risk and low risk. I think we should include it in algorithms, but so far looking at our stuff, the smaller vessel tortuosity seems a little more sensitive to differences.
Great. I think it's time to wrap up this first session. We did receive many later comments, and we will get to as many of those comments and questions as we can. But for now, I think it's time for to end this session and move on, unless we have any other closing remarks.
Siddharth, thank you very much. And I apologize, you know, this is really getting complicated science condensed into short time frames is hard. And I am sympathetic to all of you that we're trying to cover a lot of waterfront, but we also want to go deeper. So hopefully the questions that you pose, we will get to the speakers and they'll get back to you in these next few weeks. We'll condense all of that so that this meeting has kind of a finish that includes all of that information. So we're going to move now to the second session, which is on Marfan syndrome, the latest. We have two moderators, Dr. Alan Braverman, who we've heard from this morning, and my dear friend Craig Miller from Stanford. So I'll turn it over to the two of you.
Good morning. Morning, Craig. We'll start this session on Marfan syndrome with a talk from Jennifer Habashi from Johns Hopkins, who will discuss pregnancy and Marfan syndrome basic mechanisms. Jen, are you able to unmute and join us?
Bruno, is Jen on the call? Is she getting in?
Yeah, can you hear me now?
There we go.
Apologies,
Yeah.
that was my fault. Jennifer should be on now.
Okay, great. So I wanted to thank GenTAC for inviting me to discuss this data. I'm going to be talking about a mechanism and treatment strategy for pregnancy-associated aortic dissection and Marfan syndrome. I think as everyone knows in this meeting, there's an elevated risk of aortic dissection observed during pregnancy and the postpartum period, which has been quoted to be anywhere from 3 to 15%, with higher risks associated with aortic root diameters greater than 4 centimeters. This also includes an elevated risk of a type B dissection. However, we're still learning about the risk factors, which have been less well studied to date. For both, though, the risk has been shown to increase throughout the third trimester, and particularly in the postpartum period. So based on our understanding of TGF-beta and ERK signaling in aneurysm progression, we sought to understand whether altered cellular signaling was responsible for this elevated risk. In particular, we noted that the release of oxytocin rises throughout pregnancy, peaks in the third trimester, and is sustained throughout lactation. Furthermore, prior research has shown a connection between oxytocin and TGF-beta signaling, with oxytocin activating ERK signaling through the PKC pathway. So using the MGR mouse model, which is a particularly severe Marfan mouse model, we observed a dramatic dissection rate of 91%, shown in blue. And those dissections occurred almost exclusively in the postpartum period. Simply removing the moms from the pups and preventing them from lactating decreased the rate of dissection to 26%, shown in red. We found that blocking ERK with trametinib also resulted in near complete protection. And then by Western, you can see that the predisposition for pregnancy-associated dissection was proportional to ERK signaling within the proximal aorta. So based on this, we treated the mice with an oxytocin antagonist via continuous infusion starting at the beginning of the second trimester. And this reduced the rate of dissection to 6.7%. Interestingly, the dose we used was only a partial blockade because the mice were still able to lactate. We also treated with hydralazine, which reduced dissections to 5% in the postpartum period. Both of these treatments have been shown to work by reducing ERK signaling by the PKC pathway and are both approved for use in pregnancy. Although oxytocin antagonists are still under development, they're used primarily for preventing preterm labor. So this new understanding of the role of oxytocin in the increased risk of dissection in pregnancy will hopefully lead to further development and possibilities for productive treatment options for women with Marfan syndrome and related connective tissue disorders. Lastly, we have repeated many of these studies in our vascular Ehlers-Danlos model with very similar results. Thank you.
Thank you, Jen. That was a really interesting overview of this important research on pregnancy and outcomes. I'll start with one question. Have you looked at the same sort of a study in the mouse model that's used typically in the losartan sort of response to see if the pregnancy and oxytocin seem to play a strong a role?
Yeah, the problem with that mouse model is we don't see dissections in pregnancy in those mice, so we haven't been able to study that. We have found hydralazine is effective in preventing aneurysm progression. We haven't tried the oxytocin antagonist because we don't see a fast enough progression of aneurysm to be able to really study that.
The reason I ask is because women ask about this concern about pregnancy, of course, and breastfeeding, importantly, because of the work that you and others have done in this arena. And since dissection is pretty uncommon for women with Marfan who have small aortas, and do you think that oxytocin and breastfeeding is an important thing to mitigate or discuss in small aorta women with Marfan syndrome who have pregnancy?
So we do discuss the data mainly because most of our patients come with a lot of education about the topic, and our practice, my practice typically is the same as going into pregnancy. If their aorta is less than 4 centimeters, we typically support whatever decision they make and just follow them more closely in the postpartum period if they opt to breastfeed, which I would say the vast majority of our patients do opt to breastfeed.
Thank you. There's a question from Kim Eagle about, Jennifer, about should we use a beta blocker and hydralazine in this population who are contemplating and going forward with pregnancy?
So we do typically treat with beta blockers. I didn't show here, but use of propranolol in the mouse model had a very modest preventative effect, much less so than hydralazine or oxytocin antagonists. We still do use them. For hydralazine, we have not yet started to use hydralazine, certainly not routinely. We have a couple patients who came to us knowing this data who requested hydralazine. And we did try hydralazine in 1 or 2 patients. And And they had a hard time tolerating the doses that we felt were needed. So it was not as easy to titrate up the hydralazine as we were expecting.
Thank you. One other question is posted. What role would hypertension play in pregnancy-related dissection? And could blood pressure lowering be the reason in the mice why hydralazine works?
Yeah, it's a very good question. I would argue that it's not only hypertension, because we treated with propranolol at blood pressure matched doses, and it was much less effective than hydralazine.
Great, thank you. Thank you very much for the very interesting talk. I'll move on and introduce the next speaker. Mary Roman from Cornell is going to also discuss pregnancy and Marfan syndrome and discussing the clinical aspects and clinical reasoning. Unmute, there you go.
Yes, right. Okay, so thanks very much for the invitation to speak. And basically in the course of my talk, I addressed 4 topics that result in these take-home messages. And my talk was not basic mechanisms, but rather clinical reasoning. So in any event, my first question was, what is the magnitude of dissection risk in women with Marfan syndrome? And I think that we now have better contemporary data wherein there's not a publication bias to exaggerate the risk. And I cited 3 studies, all of which have very similar dissection risks. The first was our GenTAC registry that had a pregnancy-associated dissection risk of 3.5%. The second, our Cornell aortic aneurysm registry, where it's 3.4%. And then finally, the data from the Paris group, where it's 3.8%. So those are all strikingly similar dissection risks. But what's really important is that roughly half of the women who had pregnancy-associated dissections, primarily those with type A dissections, were unaware of their underlying diagnosis. So if we assume that those type A dissections could have been avoided by counseling against pregnancy, presumably because of large aortic aneurysms, we're left with a dissection risk that may be somewhere in the 1.5 to 2% area. And so I think that that's very useful for us when we counsel our women who are considering pregnancy. And also to note that most of these pregnancy-associated dissections in women who are being followed are likely to be type B. The second question was, what is a so-called safe aortic diameter? And has been stated, the general US guidelines, consensus documents generally state a threshold of 4.0 centimeters, whereas the European guidelines suggest less than or equal to 4.5 centimeters, with individual counseling in those women who fall into that 4.0 to 4.5 centimeter category. And I presented a couple of studies that show, both from Paris and from Salt Lake City, that show that women whose pregnancies fall into that 4.0 to 4.5 range, who are followed using a multidisciplinary approach, do not experience type A dissections. And I also presented our prospective data from Cornell that confirm that. So one of my wishes is that we can all work together to try to update our US consensus guidelines. The third question was why many dissections occur peripartum. And Jen Habashi has addressed some of the potential mechanisms, including hemodynamics and the oxytocin hypothesis. It was interesting to me to hear that this is something that is not seen in, I guess, what might be called standard mouse models of Marfan syndrome. In any event, I think it's important to remember that some of these hemodynamic changes, particularly the increases in stroke volume and cardiac output, do persist into the postpartum period. They don't stop with delivery. And the final question was why type B dissections occur. And I think that we have very limited imaging data to suggest that pre-existing descending aortic aneurysms exist and thereby predisposed to dissection. But the limited data that we do have suggests that that is not the case. So this, I think, is an area of great concern and great need for research. And one potential hypothesis for this is that it, there may be more than one pathogenic variant in addition to the FBN1 that predisposes, but that's really pure speculation. So with that, I'll stop and try to answer any questions that you might have.
Thank you, Dr. Oman. That was wonderful. Good to hear your talk. And I think it's important that you mentioned about the aortic diameter threshold for the ascending aorta when counseling women. And the European guidelines do say, I think, 45 millimeters as far as heightened risk, and I think an individual decision making is between 40 and 45. In our population, we have had one woman who dissected under watch on beta blocker at 42 millimeters. So it does occur, and I don't know that we really have a good idea about the frequency, but I think, informing and sharing a decision about that risk in a paper that'll be out next week on the IRAD experience in JAMA Cardiology will have, I think there are 3 women with modest ascending aortic dilatation known before the dissection were between 40 and 45 millimeters. But we don't know the numerator or we don't know the denominator in that group either. Let's see the other questions. Another question about lactation. Mary, would you like to weigh in on your advice on lactation with regard to this concern?
Sure. So I suppose not surprisingly, we don't have systematic data in the medical record about lactation. But what we have been doing at Cornell is both retrospectively and prospectively eliciting information about lactation. And so far, we have not seen any association between lactation and dissection. But of course, that's difficult because we've had so few dissections, but there's no obvious signal in our population.
Thank you very much for that very informative and important talk. We'll move on now and hear from Marian Hoffman-Bowman. Good morning. Marian's going to discuss medical treatment of Marfan syndrome.
Good morning, and thank you for inviting me and to this really exciting meeting. I think several of the speaker and the pre-recorded presentations has really focused on the importance of the optimization of common cardiovascular risk factors. We have heard several reporting on really targeting low normal blood pressure in patients with Marfan disease and other aortic disease. In this context of treating hypertension, I thought that the presentation from Dr. Turani, which was featured in the poster presentation, was very interesting, that he showed that there was a protective effect of irbesartan in the Marfan mice, and that this effect was, at least in part, mediated by eNOS. Now, eNOS is a really complicated and important pathway and very, very closely related to endothelial dysfunction. So I think there are so many studies that show that lifestyle modifications, smoking cessation, treatment of hypertension, statin treatments with their pleiotropic effect, they all affect eNOS. So I kind of really think that brings it together that we cannot undervalue the importance of preventive cardiology to keep the aorta healthy. Another aspect in this meeting I thought was really important by a contribution of Dr. Turney from Stanford, showing that physical activity can reduce aortic stiffness in children with Marfan's disease. Now, this was obviously a very small and kind of preliminary study, but it kind of fits into the larger theme that we have to look for new approaches, how we can optimize cardiovascular health in patients with Marfan disease, to harness really everything we have available to reduce the risk for dissection. I thought a really very important, meaningful contribution in the last few years was the study from the UK, the AIMS study, showing that irbesartan reduces the aortic size over a 5-year follow-up period, treatment period and follow-up period. And this treatment was associated with an approximately 10 millimeter reduction in systolic blood pressure. And in the study, the patients really all started out with a normal systolic blood pressure of around 110, and that increased in the control group to 120 and remained flat in the irbesartan treated patients. Irbesartan obviously is a more potent blood pressure medication than losartan, has a longer half-life, may have additional effects, maybe enos. So I think I have started in my practice to start shifting patients from losartan to irbesartan, particularly if they are hypertensive. And using really a 24-hour ambulatory blood pressure medication as a treatment, as a surveillance tool. Another point I want to point out is the importance that family members of patients with hereditary disease or Marfan disease need to have repeated imaging, and the importance of updating the family history at the clinic visits when we see the patients over the years. And what I find often is that the children may have been screened like 10, 15 years ago when they were quite young, and really telling the patient that the kids need to be rescreened in their 40s and 50s. And there was some kind of really interesting data that we miss aortic dilatations in patients at risk if they are under the age of 40. And that kind of relates somewhat back to the discussion that we had earlier this morning. How aggressive should we be with genetic testing in patients with aortic dissection? And I really think it is very important to make this an individualized shared decision in conjunction with the genetic counselor to really decide if a patient with dissection should undergo genetic testing. And I agree with what was said earlier, that we probably need to expand this to patients into their 60s, because with good lifestyle changes and medication use, dissection, despite underlying genetic susceptibility, can be seen now at a later age point. So I often find genetic testing in the index patient really helpful to manage the risk of the family members. And I would like to kind of really pay attention to the fact that we need to maybe patients that we initially identified as being at low risk, that they really need to be re-imaged as they get older. And lastly, just a few words to the importance of the flu vaccine, maybe this year more than any time ever before. So we kind of really found a 30% increase in the frequency of aortic dissection during the flu season that was associated with a 2-fold increase in mortality. There are obviously mechanistic data and studies needed to see if this is just an association or maybe there's causality. But as Dr. Scott Lemaire kind of pointed out in his talk, there are kind of new emerging data that maybe pneumonia and infection could be is seen in patients with aortic dissection. So I kind of think the concept that infections and flu particularly might be related to as a triggering event in patients with underlying susceptibility is something we kind of should focus. No matter if this is related or not, the flu vaccine is obviously indicated or recommended everybody over the age of 5-6 months. And one last comment is we found that the cardiologist particularly has a very important influence on the patient. Patients are not aware of the association between influenza and heart failure, heart attacks. And we had a very short intervention in our cardiovascular clinic where medical students educated patients about the risk of flu and heart disease. Patients did not know about this. And importantly, those really short intervention of 3 to 5 minutes changed the mind in 30% of patients who was undecided if they want to get the flu shot. So I kind of really think that we as cardiologists have a specific role in really educating our patients about the importance of flu, and it may relate to aortic disease, but certainly relates to other cardiovascular morbidity. Thank you.
Thank you, Meredith, for that talk. And there are some questions online that if you would be able to address that for our audience. We'll move on now, and Craig Miller will moderate the second half of this session.
Good morning, everyone. It's early morning here in California. We're going to turn next to some exciting new imaging techniques about how we dynamically get a handle on the aorta, not just morphology and size. We're starting with Jonathan Weinsaft, who is the head of the cardiac MRI program at Cornell. Jonathan, are you live and up? I think you have to unmute. Unmute, Jonathan.
Yep. Hi, all. How are you? Thanks very much for inviting me and for giving me the opportunity to present my talk today. So what we focused on in terms of my full talk was new imaging approaches, focused both on use of molecular imaging via hybrid PET MRI and hybrid PET CT approaches, which have demonstrated evidence of upregulated metabolic activity in patients with Marfan syndrome. Altered flow physiology, as alluded to by Shane earlier in her talk, and worked on by our group as well, using techniques such as four-dimensional flow MRI, as well as new strain-based techniques including echo-based strain in patients pre and post aortic root replacement, as well as unselected patients with Marfan syndrome and genetically mediated aortopathies. The key points that we emphasized in terms of our talk is that while current imaging approaches predicated on aortic size are powerful predictors of generalized outcomes in patients with genetically mediated aortopathies, Marfan syndrome, and otherwise, these approaches are limited. And certainly we know that events can occur in patients who are below established thresholds, and that even in patients who've had ascending aortic replacements via surgical grafts, in some patients, risk for type B aortic dissection persists. And better understanding that risk is a key focus of our research here at Cornell. We've used new imaging approaches, as I alluded to earlier before, both PET, hybrid MRI, as well as biomechanical imaging using strain-based techniques to demonstrate changes between aortic subtypes, and also to demonstrate longitudinal changes that occur in the descending thoracic aorta following ascending replacement. We demonstrated that placement of a tubular graft in the ascending aorta increases energy propagation to the descending thoracic aorta, resulting in increased distensibility in the descending aorta, which varies based on aortic pathology. What the long-term implications of those changes in strain, those increases in energy delivery to the descending aorta are uncertain. And that's a key area of our research focus, namely, does the graft in some manner contribute to post-operative long-term risk? And can new strategies for graft design and otherwise mitigate that risk? And those are areas of obvious research focus. There's certainly important knowledge gaps that are worth addressing.
Thank you, Jonathan. This is fascinating work. I encourage all the participants to look at Jonathan's talk on demand. And there's nothing more distressing to the patient and the surgeon after a beautiful whatever you do in the ascending arch to have them come back with an acute type B dissection, including those in the first few months after a pregnancy, as we just heard. It's life-threatening and it's life-changing. And I wonder if there's any room here, Jonathan, in your work to look at various physiological, pharmacological approaches. Say, for example, in the postpartum woman, are ARBs and ACE inhibitors bad? Should they all be on hydralazine? What can we do to prevent this devastating late complication downstream?
Well, we certainly don't. Those are great questions, and they're questions that we certainly don't know the answer to. Our approach has been to look at this through a two-pronged mechanism. The first being very, very carefully controlled, tailored imaging studies using prospective data sets. And we've presented some of that data in our talk today. We're increasingly trying to harness the power of artificial intelligence in terms of some of the work that we're doing to better understand both the modifying impact of pharmacotherapies, as you alluded to, Dr. Miller, as well as whether preoperative or maybe postoperative imaging characteristics in large data sets can help to predict subsequent events. We simply don't know the answers to those, but those are important issues.
Well, let's let all of us not forget those unanswered questions and whether we're doing something bad downstream. And I'm afraid we are when we eliminate the Windkessel and the natural physiology. I've gotten the buzz from Kim that we're behind, Jonathan, so thank you so much for that. And we're going to have to move on to the next talk. Speaking of drugs, this is by Scott Lemaire from Baylor in Houston. He's going to tell us what we know or don't know about calcium blockers and the fluoroquinolones, the antibiotics. Go ahead, Scott. You have to unmute, please.
Yes, thank you. See if I can get the video working here. Hey, good morning, everyone. So 3 key points related to calcium channel blockers and fluoroquinolones. The first is that data suggests that calcium channel blockers may be beneficial in patients with type B dissection, but should be used with caution in patients with Marfan syndrome and other forms of heritable aortopathy. And this is based on a single paper published by the Hopkins Group in 2015 that featured 2 distinct studies. The first in a mouse model using mice with the 1041 mutation in the fibrillin-1 gene. Those exposed to amlodipine or verapamil exhibited exacerbation of proximal aortic manifestations. The second study involved use of data from the GenTAC registry, in which they identified patients with Marfan syndrome who received calcium channel blockers and found that those patients were at an increased odds of aortic dissection and aortic root surgery versus the comparison group of Marfan patients who did not receive calcium channel blockers. Certainly we need further data to assess whether calcium channel blockers really introduce a risk in these patients, but the initial data from the Hopkins Group is concerning. The second point is that it remains unclear whether fluoroquinolones cause aortic aneurysm or dissection in patients without pre-existing aortopathy. So far, there have been 6 retrospective studies involving large national or regional administrative databases, and these have been published between 2015 and then there were 2 in last month. Two were published in September of 2020. Several of these studies have demonstrated an association between fluoroquinolone exposure and aortic aneurysm and dissection, but the more recent studies with designs meant to reduce bias in the studies have actually challenged this finding. Importantly, no studies have evaluated the risk of fluoroquinolones in patients with existing dilatation, aneurysm, or dissection, and no studies have evaluated the risk of fluoroquinolones in Marfan syndrome patients or other patients with heritable forms of thoracic aortic aneurysm and dissection. The final point is that 2 studies using established mouse models do support that fluoroquinolones should be avoided in patients with aortic dilatation, and in those at risk for aneurysm or dissection. The first was a 2018 paper we published in which we studied the high-fat diet angiotensin II mouse model of sporadic aortic disease and found that those challenged mice exposed to ciprofloxacin had significant increases in aortic aneurysm, aortic dissection, and rupture. In the second study, which is currently in press in JTCVS and should be released very shortly, we actually studied the effects of ciprofloxacin in a Marfan syndrome model using the 1041 mutation of the fibrillin-1 gene model. We found that the Marfan mice that were exposed to ciprofloxacin had significant increases in severe aortic aneurysm and dissection and increases in rupture rate. So I'll stop there, and I'm really happy to answer any questions.
Thank you, Scott. So mouse model wise, we think we know what we're doing, but clinically we're as blind as a bat. Would that sum it up?
Yes, and I think the distinction here is that we're looking at something, and that we're not looking at a potential treatment, we're looking at a potential risk factor. It's one of those things we're never going to have robust prospective clinical data on either of these issues, ever. And so we have to decide at what point do the balance of retrospective clinical data and experimental data using either cell or mouse models provide enough convincing evidence of a concern that we should change practice. Frankly, I think we're already there, at least in the setting of patients with existing aneurysms or patients with Marfan syndrome. I still believe it's a stretch to consider these drugs dangerous in patients with hypertension or atherosclerosis, which are currently included in the FDA warnings, for example. So we are a bit blind, but we're hopeful that the combination of population-based studies and basic science studies will provide as much guidance as we're ever going to get.
Greg, it's Greg, important for the learning audience to know that the GenTAC study that suggested calcium blockers might impose risk in Marfan subjects, those patients were those who had a native ascending aorta. So I certainly don't think that we can extrapolate that data to someone who's had their ascending aorta replaced. And I totally agree with Scott that we do not want to overinterpret these data to all people who have an enlarged aorta. I think that's a gross overstatement.
Good point. There's a question from the audience, Scott. How long do you treat the mice with the fluoroquinolones in your studies and in the Hopkins studies?
Yeah, it's a great question, and it's one of the, I think, one of the limitations of our two studies, in that we exposed the mice to ciprofloxacin for 28 days, which was based on we wanted to give them the drug during the entire time they were stressed with angiotensin II in the first study, and then we carried that forward into the second study. It's a fair criticism because that's obviously a longer period of exposure than what we would expect in patients. However, I think it's important to note that in the first study, the sporadic mouse model, 6 of the 7 deaths in the mice that received ciprofloxacin occurred within 7 days of exposure. So we were seeing profound deleterious effects within the time frame that you would expect a patient would be exposed to these drugs. And it wasn't like these things were occurring far out after 3 or 4 weeks of exposure. Similarly, in the Marfan study, more than half of the deaths occurred within 14 days of exposure. So I think that helps mitigate against the criticism that we gave the drug for too long.
Okay, thank you very much, Scott. We've got to move on. We have Tom Gleason next, who is going to talk about geometry, genetics, and patients. Not patients, but patients. Tom has recently moved to the Brigham and Women's Hospital in Boston from Pittsburgh, and he has some pretty neat stuff to share with us. Take it away, Tom.
Thanks, Craig. I want to thank particularly Kim and Josephine for the invitation to participate, and it's great to hear everyone's voice, if only remotely. And so anyway, this in some ways is relevant to Jonathan Weinseff's talk in a sense. and I'll get to that. I spend some time in this presentation talking about the nuances of genetically triggered aneurysms and their surgical management with respect to the fragility and friability of these tissues, which is somewhat distinct from some of the other degenerative forms of aortic disease. And then I spend some time just reflecting on what are the surgical options right now, but I spend most of the time talking about this concept of a focus on form and recapitulating what would be optimal form for a given root reconstruction. And I think some of the folks on the panel know that this has been an interest of mine for some time, and I speak in particular about some of the many iterations of the valve-sparing root approaches to aortic root replacement and how they've differed and what their impact has been. I will say that I think that we're still not there yet in identifying the optimal way to reconstruct these, and I would highlight the following point, that we honestly have very little long-term data published. There have been a few, notably folks like Tyrone David, who have presented their long-term series, but the numbers are small. And the reality is, as those of us know, in busy aortic centers, we see patients back. I've been in Boston only a few months now, and I've already seen a couple patients that were done in this area with valve-sparing root approaches in less than 8 years back, coming with significant aortic insufficiency and needing reoperations. So I don't think that we've achieved, the ultimate optimal repair strategy. But I do believe that a focus on recreating optimal form will generate long-term function. And I would close in kind of a corollary to what Jonathan Weinseff's presentation was about. I emphatically agree with the concern about the loss of the Windkessel effect with graft placement, and the fact that we don't even have an optimal aortic replacement material. While Dacron grafts have been obviously revolutionized our ability to care for these patients, particularly in the acute and subacute way, we've only now recognized that they do have a long-term impact, and they both impacting the heart and left ventricular function, but also downstream impact on the aorta. And I think this is very relevant and will be a key feature to research moving forward, identifying potentially different material constructs that could be utilized in combination with refinement of surgical techniques. So that was the gist of my talk, a fair amount of nuance, but perhaps relevant, particularly for long-term outcomes.
Thank you, Tom. I'd like to refer everyone to Tom's prepackaged talk. It's very good, very worthwhile. To illustrate how important this late downstream adverse effects we may be creating, in David's most recent update, 465 patients at 20 years, the incidence of late downstream dissection in patients with connective tissue disorders was 20%. 20% at 20 years, whereas it was only 5% in those without a genetically triggered aneurysm. And it's just something we have to focus on and do better in the future. And someday, as Jonathan had in his talk, we're going to see the strain analyses, but also the wall stress analyses. And we've just got to crack that nut and do something better to avoid these late devastating consequences. Any questions? Let's see what's up. Nothing from the audience there. Any other panelists have questions of Tom?
Craig, this is Kim. Tom, I really love your work, and it really is. It seems incredibly scientific. One of my questions to you is, as you teach trainees, how hard is it to transmit these nuances in surgical approach to trainees? Do they adopt easily? Do you feel like this is something that is easily taught or not?
That's a great question, Kim, and one that's often asked. And I will say that it's not easy, and I think that the real issue is that it does require perhaps a more distinct focus on some concepts that we don't necessarily focus on in the rest of the cardiac surgical kind of parlance and day-to-day working. So, but I will say that I have translated it to some, and I think it's one the real catch point of success. I think relates to just keeping one's interest in this concept, and because patience is the point. To do this, it does take some patience. I think there's a tendency to grab onto surgical techniques that are easy, and the reality is these aren't easy, and it does require some more focus. But the short answer to your point is that it is teachable, but it does require perhaps a little more focus than some of the more mundane procedures we do, like aortic valve replacement.
Thank you, Tom. I have always felt that the finest surgeons I've worked with were artists. They looked at a problem just somehow differently, and somehow coupled that ability to create art, but also with speed in the operating room. And so, your stuff is really, really interesting. I think it's futuristic, but it's going to take the right trainee to adopt that and become an artist like you are.
Well, we all have to strive to do that. For the audience's sake, Dr. David's updated results, 35% of the patients had Marfan syndrome. Only 14% had a bicuspid valve. Many on the panel know that he is incredibly picky and super selective, and I congratulate him for that. Maral Ozunian had the paper in 2016 where they had 616 patients in Toronto on paper, all set for a valve sparing. Yet, Tyrone and his colleagues, Chris Findell, only preserved 41% of the valves. And that explains why his valve sparing results are so spectacularly good, although in the current paper, not perfect. But you've got to be selective. You've got to be an artisan in your brain and use judgment, Kim, as well as with your hands.
Absolutely.
Can I just add one point? I think that's an absolutely critical point that Craig makes. And I would add to that, a point that for my concern is that folks that are out there doing this work are really not following their patients long-term. So they're not seeing what happens with the strategies they've used, and that perpetuates perhaps some errors in judgment on what techniques to use when, without that really rigorous follow-up.
And as Tyrone tells us, the only good thing about a socialist healthcare system is that he gets to do echoes every 2 years forever. And he's the only one who can do that. We have to scrounge. By the way, in his most recent update, in his expert hands and with his ultra selectivity, there was a 6% reoperation rate at 20 years, and 15% of the patients at 20 years had 3 or 4 plus AR. So it's still not perfect, but no one can match Tyrone's results for many reasons. But we don't want to dabble, and I really don't think, now that I'm a little older, I've been at this for 22 years. We did our first one in '93. I don't think we want to push the envelope too far, especially with the bicuspids, which some groups continue to advocate for. It's not fair to the patient.
I want to thank you, Craig and Alan, for moderating that session. It was just terrific. I think we'll go ahead and move on now to the next session. And I want to introduce Catherine Holmes from the University of Oregon, who will be our moderator. Catherine.
Good morning. Thank you, everyone. It's still dark here in Portland, but otherwise we're doing quite well here, and I really appreciate the ability to moderate this session. It's a wide variety of panelists that we have speaking here from bench to bedside, and we will start very quickly with the population-based approach. Kim, we're going to give the mic back to you to give us an update on IRAD.
Thank you, Kathy. My comments will be brief. I hope that you can look at the 12-minute and 37-second talk that I have listed on HUVA. And much of the data that I went over in my talk is from the IRAD registry. And I think it's important to note that really today, the best test to find acute aortic syndromes continues to be a careful history, physical exam, ECG, and a chest X-ray. And then when we do that properly and we identify predisposing conditions, certain clinical findings that are most robust and common, and findings from the EKG and the X-ray, we think we can probably identify about 95% of acute dissections today if we simply did that. I think another thing that's become pretty clear is that we do have an excellent, highly sensitive biomarker for dissection. It's D-dimer. It's probably 98% sensitive for patients with dissection. The negatives are perhaps small intramural hematomas with not a lot of clot. Obviously, this is not a specific biomarker, so we're still waiting for perhaps a biomarker to add to it that would give us a platform of 2 or maybe 3 biomarkers that together would be highly sensitive and specific. And I'm waiting for Scott Lemaire and his team's work on fibrillin-1 to see if that will be the biomarker that reaches this goal. As we've looked at IRAD over the last 24 to 25 years, what's very clear is that the mortality is falling. And I think there are a variety of reasons for that. Clearly, imaging has gotten better. I would say our interventional colleagues, surgeons and endovascular specialists are taking on more difficult cases. We're not denying patients simply by virtue of age so much. We're operating on patients who have had a coma or a stroke because we know many of them reverse. So that's really gratifying to see. We still are sobered by this data showing that most dissections do not occur in aneurysmal aortas, or at least at the size that you and I would currently use for a surgical cut point. 60% of type A dissections are less than 5.5 centimeters in size. And this really calls then for the need for the Alliance and all of you to push the frontier of finding who is at risk that doesn't have a large aorta or a mildly enlarged aorta. And then finally in my talk, I mentioned survivorship, and Alan Braverman talked about this in his talk as well. Our studies of dissection survivors tell me that we need to do a much better job. And I hope the Alliance will take this on, that we'll develop a dissection-specific protocol for cardiovascular rehabilitation after a dissection has occurred in a patient, and that we will work hard together to find a scientifically robust way of teaching patients how to approach physical health, mental health, sexual health, occupational health. This to me is a frontier that we've ignored. I'm part of this problem, and it's something I want to see us take on in a very vigorous way. So those were the key points of my talk, Catherine. Let me see if anybody has questions. You're on mute, Kathy.
Yeah, I was just looking for the questions. Kim, how have the demographics of acute aortic dissection changed over the lifetime of IRAD? We noticed that we do have more people who have known disease prior to their dissection. Has that changed at all in what you see on the emergency room end?
Great question. So we have about 10,500 patients in IRAD. Partly because of people like Diana Milowitz's work, the number of familial folks that are in the dissection registry are increasing because we're identifying them better with both history and physical and also genetic testing. I think that probably is one of the most important changes that we've observed. Otherwise, not so much. Dissection in 1994 looks a lot like dissection in 2020, but I think we're doing a much better job of treating those patients.
Alan Braverman asked a question. I'm going to dovetail onto that. How do we get the word out about how useful D-dimer is when thinking about aortic dissections in the ER? I would add to that, how would you structure a quality initiative through IRAD to improve the overall detection rate in the ER?
That's a really good question. And, you know, we actually worked with, I believe, Diana Malowitz and the John Ritter Foundation, as well as the AHA, in creating simple messages for emergency room providers, which sort of listed the pre-existing conditions, the key presenting features that would identify, and then the keys from laboratory testing, X-ray, et cetera. So I think a national effort working with professional societies, including the Marfan Foundation, frankly, would be a great thing to do, where we bring back those kind of key things that physicians need to think about in ERs and give them examples. I think if we had Fibrillin 1, if Fibrillin 1 works, and maybe we'll ask Scott to comment on how close we are to that data, then we can offer a platform that we can prospectively study. We've studied D-dimer in about 500 patients with chest pain, and it was 98% sensitive. Some of the patients who presented after 6 hours with MI and PE, of course, had elevated levels, so it's not a specific biomarker. But we do need to get this, I think, into ERs. I personally think we should do it.
Thank you, Kim. We have a couple of other questions, but I think that we'll move on to Jay Humphrey from Yale, who's going to talk about biomechanics and aortic disease modeling. To hold the space bar.
Yes, thank you. First, I'd really like to thank Dr. Eagle for inviting a bioengineer back to GenTAC. I presented 2 years ago and talked more about experimental biomechanics. And this year, I wanted to share more on computational biomechanics. We have made some advances where we can now predict, certainly describe, but perhaps predict how the aortic wall changes over time in composition, in geometry, and material properties. And we've heard from Diana and others about the discovery of genes that predispose to thoracic aortic aneurysms that affect actin myosin, for example, ACTA2 and MYH11. And one of the questions we asked is, what is the functional consequence of those? So we compared computationally the effect of losing vessel level contractility versus losing the ability of the cells to, through actin and myosin, mechanosense and mechanoregulate matrix. And what we found, somewhat surprisingly, is loss of vessel level contractility results in a mild phenotype, at least in our numerical simulations. Whereas loss of mechanosensing or mechanoregulation through the actin myosin dysfunction leads to aneurysmal enlargement, similar to that which we see in the simulations for compromised elastic fiber integrity, as for example in Marfan syndrome. So I think that these models can help us delineate the functional consequences of some of these mutations. The second thing we looked at is, and we've heard a lot about hypertension as a risk factor, is whether hypertension can literally cause the aneurysms in these numerical arteries, or whether it's simply a risk factor. And the results suggest that indeed hypertension does exacerbate aneurysmal enlargement by increasing what we call mechano-driven phenotypic changes and in the cells, and hence the turnover of matrix leading to less structural integrity. So, and we similarly looked at aging, and the numerical model suggests that both aging and hypertension are strong risk factors, but not initiators. And finally, 2 years ago, Dr. Shane Morris talked to me about tortuosity and asked how, from a biomechanics perspective, we might explain tortuosity. And my answer was I didn't know. So we've spent some time over the last year and used the numerical model, the same model that we use to look at aneurysmal development. And what we discovered is that the native aorta, when subjected to what I'll call insults, such as local changes in material properties or paravascular tethering, or even geometric discontinuities, is fairly robust against these insults. But if that is superimposed on an underlying structural defect, as for example in Marfan syndrome with fibrillin 1 or even in fibrillin 5, based on mouse models that do develop aortic tortuosity, we found that multiple hits do conspire to lead to tortuosity. So in summary, as we all know, the aorta is remarkably robust. In engineering terms, we'd call it fault tolerant. But in cases of multiple hits, we see computationally that these tortuosity can develop, that aneurysms can develop, and indeed, due to local insults, dissections can begin and propagate. I'll stop there. Thank you very much.
Thank you very much, Jay. I encourage everyone to take a look at your talk because the graphics are very helpful in understanding the mechanics of the disease. Yeah, there you go. I'm going to pull a few of them up. We have a couple of questions here. One of them is, from Mark Lindsay, does the loss of actin myosin contraction change aortic distensibility in your models?
It does. So for two reasons. If this is systemic, then obviously changes in actin myosin will change blood pressure. But as far as locally, to answer Mark, yes, they will, changes in actin myosin will change local stiffness. But what we found in the model, and it actually surprised us, is it was the lack of mechanosensing or mechanoregulation of matrix, which led to aneurysmal enlargement, as for example, you can see on the screen in either the upper right or bottom right. These are actually experimental measurements on a fibrillin 4 and a MGR mouse. But yes, Mark, it does change stiffness.
We have another couple of questions about stiffness. One of which related to mechanosensing might induce dissection more than loss of contractility.
So our investigation of contractility in this case focused mainly on aneurysmal enlargement, and we think that it's more a mechanosensing issue when you lose actin or myosin. We have shown in other simulations, however, and actually in a mouse model, a TGF-beta R1 mutant with George Stelides, that contractility can be protective, that increased contractility can stress shield the underlying vulnerable matrix. So I think that as we look at potential interventions and particularly lowering blood pressure, it's important to relax the microcirculation, the distal bed, while trying to preserve contractility in the more proximal vessels, because that can stress shield the vulnerable matrix.
Thank you so much. There are numerous questions that are coming in related to patients that are post ascending surgery and the impact of the descending aorta. Those I'm going to leave in order to be able to move on to David Duchel, who's going to talk about TGF-beta signaling from the University of Washington with another pretty exciting talk about cell signaling.
Thank you, Catherine.
Can you hear me now?
Perfect.
Great. Yeah, this is David Ditchek with a K, not an L at the end of the last name. And I thank the organizers and Kim for allowing me to participate in this great remote meeting. So there are three major themes that I covered in my presentation. First, that TGF-beta signaling in smooth muscle cells is likely altered in several heritable human aortopathies. It's likely altered in Marfan syndrome, which is not due to mutations in TGF-beta signaling pathway. And in that context, I'd really like to acknowledge the groundbreaking work of Hal Dietz' group implicating TGF-beta in aortopathy and focusing the field on intracellular versus extracellular events in aortopathy, including signaling events. And that's a focus that persists today. as you will see in Francesco Ramirez's presentation. TGF-beta signaling is also obviously altered in aortopathies associated with TGF-beta signaling or variants, pathogenic variants in TGF-beta signaling molecules, including ligands, receptors, and SMADs associated with phenotypic Loeys-Dietz syndrome. But despite the obvious involvement of abnormal TGF-beta signaling, it's as yet unclear whether more TGF-beta signaling, less TGF-beta signaling, or both are causing aortopathies, and also whether it might be different, the TGF-beta signaling might be playing different roles earlier in life and later in life, or in one cell lineage versus another cell lineage. So there's really active investigation trying to sort that all out in mouse models. The second part was included data from our lab and others from animal models showing that smooth muscle TGF-beta signaling is essential for aortic health during development and early postnatal life. So inhibition in using antibodies, for example, done by Francesco Ramirez, or by knocking out the receptor by George Talidi's lab or our lab, either during development or in the early weeks of mouse life, causes severe aortopathy and suggests that efforts to inhibit TGF-beta in early human life are not a good idea. In later life, the role of TGF-beta signaling is less well defined, largely because we have less data. There's data from the Dietz lab suggesting that inhibition in a mouse model of Marfan syndrome is highly beneficial. The Ramirez lab has some data also that suggests that TGF-beta inhibition is possibly protective, or at least not harmful later in mouse life, and seems synergistic with losartan. But I also presented unpublished data from our lab looking at inhibition of TGF-beta signaling in wild-type mice late in life, showing that that causes aortic disease, thickening of the media, loss of normal vasomotor function, which may be harmful. However, we could also argue that it might be protective. A thick media, perhaps that would prevent against aortopathy, and loss of bioavailable nitric oxide would, according to the data from the Redondo group in Spain, potentially be protective. But at any rate, one should not expect a normal aorta, normal aortic structure or physiology in older mice and potentially humans treated with inhibitors of TGF-beta. So we really need more human data, and we're starting to get it. There's a couple of groups who have published single-cell RNA sequencing data, very exciting, from the Fishbein lab at Stanford and Scott Lemaire group at Baylor. And I think GenTAC can facilitate collaborations that help us gather these data in collaboration and move the field forward in understanding human biology better.
Thank you very much. Your talk was incredibly detailed, so I would like everyone to watch it as much as you can. We have a couple of questions that came in earlier. Is there any effort being made to get the FDA to approve losartan doses above 100 milligrams daily for treatment of Marfan syndrome so patients can get the same doses that mice got in the research study? You have comments on that?
I'm not aware of those efforts. It would be a trial that is potentially worth doing. The losartan trial published in the New England Journal was so resoundingly negative that you'd have to have a lot of hope that the dose mattered there. I'm also not sure whether losartan has its effects on the aorta via TGF-beta inhibition, but it certainly would be an interesting study to do.
Thank you so much. In the aspects of time, we will move further to Dr. Francisco Ramirez, who's going to be looking at elastic fibers and smooth muscle cells. Dr. Ramirez here.
Okay, can you hear me?
Yes, we can.
Okay, thank you. So just to follow up with the presentation of David and just give you another aspect of what in basic research we are doing with the mouse models. So one of the implications of what David said is that most likely no single drug will be enough to delay or even prevent the progression of aneurysm in different models of Marfan syndrome. So a few years ago, together with the French group of Catherine Boulot and with the computational group in New York of Ravi Iyengar, we started to do experiment using computational approaches to identify unbiasedly biological target that could be treated with drugs. At the last GenTAC meeting, I presented how this approach can be used for drug repurposing and implicitly for the identification of pathways that were not associated, believed to be associated with aneurysm. This year, I presented some unpublished data about the approach of using the same approach to identify kinase for which there are inhibitors that could then be used eventually in clinical trials. So essentially, we did the preclinical trials in which first we identified the kinase and then eliminated genetically in the mice to see how that modified TAA progression, and then use a particular inhibitor of that kinase to see if we could get the same results. You can see that in my presentation. The point that I want to make is, the most important point is that what was surprising to us, both in the experience before of the drug repurposing and this experience, is that to identify disease-connected pathway that are common both in the mouse model of Marfan and in aortic samples for Marfan syndromes, you don't need a lot of samples. As a matter of fact, you can get the results from 3 samples from the humans and 3 from the mouse. And so that was a very interesting finding, because means that we can integrate human and mouse transcriptomic data to identify both pathway and druggable target. The bottom line of the presentation per se is that we have identified this way a kinase, which is a multifunctional kinase that regulates many of the pathways that have been implicated in the aneurysm progression. And this particular kinase, IPK2, has also a number of potential small molecule inhibitors that may represent attractive new means for treatment also in human patients. And I'll leave it there.
Thank you very much. We have time for one question. Question that was posed prior to your talk is, do you think that once it's jump-started by ATR1 overactivation, increased TGF-beta signaling becomes self-sustaining and independent of further ATR1 signaling?
Yes.
That was a very quick answer. It's going to give us time for one more then. Can you walk us through how a typical patient, Marfan patient in the future, might be treated at different ages with different medications?
So we have pretty good data, and I will refer also to data that still unpublished that was presented the last GenTAC by Mary Shepard. That the period that David was referring to, the period which is TGF-beta, in which TGF-beta baseline signaling is required, is the postnatal growth period. That is also the period that it is sensitive to treatment with losartan. In her data, she showed with the MGR mouse that past P45, which is the end of vascular growth, treatment with losartan has no effect. So if I were to visualize, the first treatment would be during the postnatal life, dealing with the AT1 overactivation, and the second part, hopefully, ideally, would be trying to block the TGF-beta driving the tissue degeneration without, however, affecting the baseline of the early effect.
Thank you so much. We're going to move on to our last talk, which is moving back to patients themselves with endograft therapy by Dr. Patel. Thank you.
Good morning, and I wanted to thank Kim Eagle for the privilege of presenting here. I will start with two patient vignettes. The first being the first patient that was treated with a thoracic endograft here at Michigan Medicine in 1993. This particular patient came in with a ruptured type B intramural hematoma, received a homemade stent graft that was made on the back table, sterilized, packaged into a sheath, and delivered to treat this aortic catastrophe. And about a month later, survived this procedure, and about a month later, presented then with what is now termed as a stent graft-induced new entry tear. This patient subsequently underwent open surgical repair and died approximately 18 years later from congestive heart failure. He did not have any ischemic heart disease, but had developed congestive heart failure as a consequence. The second patient was the first patient treated as part of the FDA-sponsored clinical trial that was instituted here that led to the approval of the first endograft in the United States. And this patient was treated with an aortic aneurysm with a stent graft and survived the 5 years of the clinical trial study, but then presented 3 years later with failure at the proximal attachment zone, where the biology had progressed and where the patient's aorta had subsequently expanded, separated from the stent graft, reperfused the aneurysm sac, and required therapy for proximal extension. I believe these two initial patients really define several things about endograft therapy. The first is, this is decades old, and that biology will always win. Engineering, which we use to advance therapy, has to play catch up. 2 years ago, we presented a study combining both computational aspects as well as imaging that suggested that the placement of a thoracic endograft in the descending aorta significantly increased the load on the heart by elimination of the Windkessel function, and that patients' left ventricles developed left ventricular hypertrophy over the span of 1 year. It is these types of newer problems, such as this consequence of loss of Windkessel function, as well as identification of what is now termed as stent graft induced new entry tears, or alterations in blood flow that can occur as a consequence of placing stiff endografts in the descending aorta, that arise when we solve or partly solve older problems such as aneurysms and exclude them by novel techniques such as endograft therapy. There is a reason Einstein was Einstein. He started first with a thought experiment, and then subsequently the experimentalists went and chased his findings. In contrast, in medicine, what we do is the opposite. We try to institute the experiment first and then chase it with identifying the theory behind it. So I do want to acknowledge the fact that endograft therapy is decades old now. The treatment zones are expanding now to include the ascending aorta in complicated scenarios such as type A aortic dissection, but that biology will ultimately define the success of this therapy, and that we have to continue chasing the biological limits of with novel engineering approaches to increase both the pathology range that we treat, as well as reach parts of the aorta that were previously termed untreatable. So I appreciate the opportunity, Kim, for your and your kind invitation for presenting at this wonderful symposium. Thank you.
That was fantastic and really nice nod to the biology that was also presented in this talk. Question for you is, if you could change one thing about current endografts, what would that be?
I think I would suggest that we consider very strongly thinking about making more compliant endografts. Something that when we use in, for example, younger patients, that it will mimic the function of the aorta. It is not just a tube. It has a function that will have significant long-term impacts. And in fact, that first patient who died of congestive heart failure 18 years later may have had a consequence of a stiff Dacron, open Dacron graft in development of his long-standing heart failure. So I think I would change the material to make it something more biologically similar.
Thank you so much. I will turn it back to the engineer of this meeting, Dr. Kim Eagle.
Thank you, Kathy. I appreciate all of those talks were just great. And if you did not get to see the plenary addresses, please go into HUVA and look at them. They're just absolutely profound. You know, this is the 6th scientific summit that I've had the pleasure of working on. And it's really interesting. Not one of them have we found ourselves able to stay on time. And that's because of the passion of the people involved in the Alliance and the science that they're chasing. Having learned that over 14 years, I built a 30-minute coffee break right into the middle of this morning, knowing full well that we would fill it up with science, and we have. But I would invite you to take a 5-minute break for whatever reason you might need, and we're going to come back and go into the next session at that point. As a final comment, the questions and answers that you're posing, we will get to the speakers, and we will get those back to you so that the answers to your specific questions are not stifled by our time frame. So we'll be back together in 5 minutes. Thank you. Hello, everybody. I think that we'll get started. One thing I've also learned is that there's nothing that our attendees like less than finishing way, way late. So we're going to try to stay on time. We're going to now switch gears and talk about Turner syndrome. And I'm delighted that my good friend Cheryl Maslin will moderate that session. Cheryl, take it away.
Hello, everybody. Thank you for the opportunity, Kim, to moderate and participate in this session. In this session, we'll be talking about Turner syndrome. And as my colleague, Michael Silverbach, demonstrated some time ago in a study that he did, that women with Turner syndrome develop aortic dilation and dissection at rates up to 50 times greater than the general population. And so we are very much interested in the genetics of Turner syndrome aortopathy. So I will start off with my presentation here, and which is covering the genetics of Turner syndrome aortopathy as we understand it to date. And so Turner syndrome, as you know, is due to the loss of a second sex chromosome. And bicuspid aortic valve disease and thoracic aortic disease and Turner syndrome, we've found over the years has a heterogeneous genetic etiology that includes loss of probably a second X chromosome that is the important factor here, combined with altered expression of autosomal genes through various mechanisms, including single nucleotide variants, copy number variants, and probably epigenetic variation. And so what we know about Turner syndrome is that loss of that second X chromosome, and this is a hypothesis that we've had for a while, which is supported by several studies now, that loss predisposes individuals with Turner syndrome to be particularly sensitized to other types of variation in their genome, or perhaps also epigenetically, that will contribute to the cause of bicuspid aortic valve and aortopathy in Turner syndrome. We've shown in a study that my lab did that about 20% of cases are due to an interaction between functional single nucleotide variants in the gene TIMP3 tissue inhibitor metalloproteinase 3 on chromosome 22. These variants are functional in that they reduce TIMP3 expression, but they appear to be benign in the general population. But when combined with hemizygosity of TIMP1, which is the paralog on the X chromosome, that it increases risk by greater than 12-fold for having a bicuspid aortic valve and associated aortic disease. Siddharth Prakash, and a study that was done collectively with GenTAC, also demonstrated that polymorphic duplications or copy number variations encompassing the genes SLC2A3 and SLC2A14, and I think that might be a typo. I think that might be SLCA10, but and none on GP1 on chromosome 12, significantly associated with bicuspid aortic disease, coarctation of the aorta, and in particular aortic dissections in Turner syndrome. And these copy number variants that are deletions of these genes are strongly associated also with aortic, or with congenital heart defects in 22q11 deletions, and in particular SLC2 genes, which are glucose transporter genes, are known in functional studies, including mouse models, to be associated with cardiovascular defects, including aortic dissection. And so we believe that these are examples whereby variants in the genome are associated with aortic disease in Turner syndrome. And then we've done a pilot study in Turner syndrome showing that epigenetic modification of genes in the Notch1 pathway are also strongly associated with aortic disease. Unfortunately, the follow-up study, the larger study, was delayed by not only the pandemic, but by wildfires and dense smoke in Oregon. And so we just downloaded the data yesterday, and we'll be analyzing it. So I'll be excited to be able to share in the future epigenetic changes associated with aortic disease and Turner syndrome. So with that, I'll open this for questions.
Could I ask you, Cheryl, is there a genetic test for TIMP1 and TIMP3 now, or do you anticipate that in the future?
So this hasn't been something that has been taken to clinical relevance yet. I think that we need follow-up studies to validate this, because this was based on a single whole exome sequencing study that we did. And but our goal is, of course, to have this validated and to move forward with it with an ideal goal in the future of actually having it not only be a genetic test, but lead towards therapeutics.
Thank you.
Am I supposed to be seeing questions here? I'm not. Okay. I do have one from an attendee. How do you think these findings might relate to gender differences seen in other HTAD? And I think that one thing is that we believe that hemizygosity of TIMP1 on the X chromosome, as seen in Turner syndrome, but also seen in euploid males, may be a predisposing factor to the increased bicuspid aortic valve disease in males versus females in the euploid population. I don't see any more open questions, so we can continue to the next talk on the incidence, management, and outcomes of Turner aortopathy and aortic valve disease by my colleague, Dr. Michael Silberbach, a pediatric cardiologist here at OHSU.
Good morning, everyone. Kim Eagle, thank you so much for inviting me to this great conference. Really fascinating talk so far. I am going to talk about my presentation on incidence, management, and outcomes of Turner aortopathy and aortic valve disease. My actual title was also When to Worry. So this is sort of a clinically focused discussion as opposed to the genetics and signaling that we've been talking about. But my interest in Turner syndrome has led me to become very interested in looking at epidemiological issues related to aortic dissection and Turner syndrome. And the first major point that I tried to make in my talk, that it's clear that aortic dissection occurs at significantly younger ages and at smaller diameters in Turner syndrome versus non-Turner syndrome populations. And by that, I mean that aortic dissection in women, as you know, is vanishingly small, particularly at an average age of 30 years, whereas the IRAD data would suggest that in women, aortic dissection occurs somewhere in the mid-70s. So that certainly is important in terms of young women coming into emergency rooms with complaints of chest pain who are then treated for indigestion and the like. And so one of my big roles has been to have our Turner syndrome population aware of the risks they have so that they can inform ER docs and their own physicians of the risk that they have. The second major point is that there, in generally speaking about congenital heart disease, there is a significant disease burden of left heart obstructive disease and aortopathy than in the general non-TS population. And I think this has significant policy issues as it relates to a clearly underserved population that has repeatedly been shown to have significantly higher mortality than the general population. In fact, if you look at the study by Shoemaker, there is the cardiac mortality in Turner syndrome is equal to the all-cause mortality in the general population. And my final major point is that we need to have some way to normalize aortic diameters when you have individuals with such short stature. And this is particularly true for those under 15 years of age. And for that reason, along with
Shane Morris and Cheryl and others in my group, we developed Turner-specific aortic Z-scores. I should say Siddharth was also a co-author on that paper. And we found that TS-specific aortic Z-score should be used to assess risk for those under the age of 15 years and aortic size index for those who are older. And I would just like to mention as a note is when Dr. Caselli's talk, he did talk about the aortic size index, but it's important to emphasize that that's for those who are over 15 years of age. Those who are under 15 years of age, the aorta is generally larger than body size in those under 15 years of age. So it is not in any way a marker for risk. And that's for the reason that we came up with our aortic specific Z-scores. So those are sort of my major points, and I'd be happy to take any questions or any discussion.
All right, thank you, Michael. I'm looking for questions to post.
Cheryl, I posed one to Michael and you, I suppose, and that is there good evidence that tight blood pressure control, even to below kind of normal levels, prevents events in patients who have Turner's?
Well, maybe I'll jump in on that.
Yeah,
there's no Turner syndrome specific evidence. We published a paper some years back that showed that somewhere around 80% of those who have aortic dissection either have congenital heart disease, hypertension, or both. So hypertension is clearly a risk factor. And there were, I think, 35% who had no congenital heart disease. All they had were hypertension who had aortic dissections. This is a study where we reviewed the case literature and reported 86 cases of dissection in Turner syndrome. Hypertension is clearly a major risk factor for aortic dissection in Turner syndrome. And also we published a paper in hypertension that showed the really excessive burden of essential hypertension in Turner syndrome that was independent of body mass index and obesity. So thanks for asking that question, because it's probably the only major treatable cause of aortic dissection in Turner syndrome.
So Michael, a follow-up then, do you target a systolic of 120, and do you do ambulatory blood pressure monitoring to verify control if a woman has an enlarged aorta and Turner's?
No, that's a good question. Well, not 120. What we do is follow the guidelines that have been set forth by the American Heart Association, in which sex is considered female, and height are used to normalize blood pressure values. And so it's always in terms of percentiles. But yes, but we don't make any adjustments for what the standard recommendations are for what hypertension is in a child. What, did you have another question?
Yeah, I wanted to know if you tend to use 24-hour ambulatory readings to verify control. Marion Hoffman-Bowman earlier talked about doing this fairly routinely in our phenotypic aortopathy clinic, Marfan, Lois Dietz, et cetera, to verify control. Do you tend to do that?
Yeah, well, thanks for that. So you were a co-author in the Heart Association scientific statement that we published, and we strongly encourage the use of 24-hour ambulatory blood pressure monitoring. In practice, it's more difficult to do when you have, particularly in children, this cuff squeezing their arm every 30 minutes or whatever it is. And so we've had some difficulty doing it, but there's clear evidence that ambulatory blood pressure monitoring helps understanding about nighttime dipping, can help with the confusion around white coat hypertension, and we recommend it, as I said in our scientific statement.
Great.
All right, thank you. I don't see any other questions posted, and so we'll move on, and I'll invite Dr. Aaron Dorfman to join us from the Children's Hospital of Philadelphia, and His talk is going to be Pearls in Managing Patients and Families with Turner Syndrome.
Thank you very much, Cheryl. So first, I want to thank the conference organizers. I want to thank Cheryl and Michael. It's been a pleasure working on this sort of collaboration of Turner Syndrome talks together. I think the last question that we talked about, as far as hypertension, is a very good segue into some of the material that I covered. What we know is that hypertension is very common in this population, both in children and in adults. There was a recent study that showed that in a population of Turner syndrome, patients of a variety of age groups, up to 40% had hypertension, but only 8% were actually being treated for their hypertension. So what we know is that hypertension is common, and what we know is that it's under-recognized, particularly in younger kids. So one of the things that's crucial is reinforcing to patients and families that to be aware of hypertension. As Michael said, it's the one thing we can do something about. So if there is even borderline blood pressures, I do move forward with the 24-hour monitor and take a look and see exactly where is the blood pressure range. And sort of re-emphasize to the families, even if they're only seeing me every few years, that they know that if they're getting their blood pressure checked at all outpatient appointments and with their other specialists, that if they are having elevated or borderline elevated blood pressure management, that it is something that we would treat more aggressively in this population than we would in the general population, because it's the one thing we can actually do something about. Second thing that I talked about at length was pregnancy. Certainly this is a rather complicated and it's a controversial topic in the Turner's population. Pregnancy is something that people often don't think about when they're bringing in their infant or their small child into our office, but it is something that's critically important. And this is one of the conditions that does often get recognized very early, sometimes prenatally, sometimes in early infancy. And it's one of those things that parents are really fixated on. And I think it's an incredibly important issue. There's some statements from the American Society of Reproductive Medicine that says Turner syndrome is an absolute contraindication of pregnancy. And it's something that I think those of us that take care of a lot of young ladies with Turners disagree with. And that there is evidence to show that while pregnancy is complicated in patients with Turners, many have a lot of challenges getting pregnant naturally, but it is possible. And then in a broader population, pregnancy can be accomplished with the help of a fertility specialist. Sometimes this requires egg donation or a variety of other techniques, but it can be done. And so what I really try and reinforce with families, even at a very young age, is that they need to talk with their other providers about what are the options for their child going to be as the years progress. And then talk about the fact that we know that pregnancy is one of the significant risk factors for aortic dissection. And so that when the time comes that they're thinking about getting pregnant or thinking about having a family, to A, think about all the options, and then B, talk carefully with the cardiologist about what are the choices, what are things going to be like moving forward, because the answer is not an absolute no. The answer is a maybe. And as long as their aorta is not already significantly dilated and they're followed very closely during pregnancy, I think this is one of those decisions that can be made thoughtfully and collaboratively with patients, families, and a variety of specialists. Other topics that we talk about are, number one, sports participation. So unlike some of the other diseases that we've covered carefully today, there's no real risk of contact sports in Turner syndrome. And so not that the general population that we take care of, the young ladies with Turners, tend to be the ones that want to play, say, tackle football. But what they do often, what there does seem to be a genetic correlation with is gymnastics and cheerleading. And because they're young and they're small, they tend to be the ones that people want to toss like 20 feet in the air. And so that is a contact sport. Hopefully they don't fall, but it's possible. However, what I would say, and what we sort of the management to date has been, is that there really are no restrictions as far as physical activity. And if the aorta is significantly dilated, that's a different story. And then in that case, I am thoughtful and cautious about contact sports and gymnastics and cheerleading where they may be experiencing chest trauma. But overall, they should really stay active. And then the last thing is sort of what do we do about the young men with Turner syndrome? There are a small population of phenotypic males who have a mosaic Turner karyotype, as well as sort of a more broad population of patients who were born female and then identify as male, and those with intersex features. And that for that population, while this is highly controversial in the field, I do tend to treat them exactly the same as I do the young ladies, because we don't know how where the different cell lines distribute throughout the body. And so for even the young men with a mosaic Turner's karyotype, I tend to follow them all the same as far as screening. We definitely see some of the same disease in the population. I think with that, we'll move on.
All right, thank you, Aaron. I believe we have time for one question. I'm not seeing.
If none, maybe we should move on, huh, Cheryl?
Yes, ready to move on to you.
All right. Thank you very much, Cheryl. Thank you, Michael, Aaron. Great talks. Really appreciate that update. Now we're going to move to vascular EDS, and delighted to have Mark Lindsay from Boston who will moderate this session. Mark.
Hi, thanks so much to the organizers for allowing me to moderate today. And I guess we're going to dive in first with Dr. Byers, who needs no introduction, to talk about genotype-phenotype relationships in vascular EDS.
Good morning. Again, thanks to all for having us here and being part of the activities. These 3 points really just summarize the content of the slide presentations.
You're a little quiet, Peter. Can you get closer to the mic?
Well, I'll try. Does that help?
Yes.
Okay. There are 3 points here. One is that vascular EDS is genetically homogeneous. That is, it's all one gene, the COL3A1 gene. And about 99% of the people that we know about are heterozygous for mutations. That is, they have one copy of the gene that's altered and one copy of the gene that's normal. There's a very small set of people who have biallelic mutations. They have an additional complication, which is actually a brain developmental defect, which is referred to as polymicrogyria. So they have an altered structure of the surface of the brain. They appear to be intellectually okay. They are actually at risk for earlier complications than the ones who are heterozygous. So it is, the clinical picture is clinically heterogeneous. And I think that often we start off thinking about this condition as one which is always complicated by major arterial defects and bowel rupture, and that they can be picked out from a crowd without any problems at all. And the reality is that, as in with many genetic conditions, we start by looking at people who are on the severe end of the spectrum, and certainly we've seen this with Marfan syndrome and other genetic conditions. And then as we do more sequencing in people who have some of the features, we recognize that the rate of the phenotypic presentations can be very mild, and that there's a very significant set of people that probably don't come to clinical attention who have mutations in this gene that we would predict to be pathogenic, and yet have either very late complications or are asymptomatic throughout their lives. And it will be helpful in finding those people as we go through and making sure that we're not missing them and not being, because in some of those families, there's always somebody that brings them to medical attention, suggesting that there are other genetic variants that make a difference. Treatment for this condition remains largely responsive to the things that we're concerned about, and that is to complications or to control of blood pressure. The mechanisms for treatment and the reasons for treating for blood pressure are basically the same kinds of things that were talked about with the other groups, and that is the suggestion that lower blood pressure has different effects on the arterial structure, and therefore less likely to have complications. We do not have good evidence for the effectiveness of any medical intervention because the trials that have been done are lacking in power. And the thing that we try to do as much as anything is to create care teams for people, which we think are an important part of care. And the idea behind these is that care is local. This condition has a population frequency of something on the order of 1 in 50,000. The average size of a physician's pool of people that they will see over the course of a lifetime may be something like 5,000. So perhaps 1 in 10 physicians will encounter people with this condition. And so as our people go back into their home environment, most of which is away from major medical centers, they need to have a comprehensive program to help care for what's going on. It should be centered in the primary physician, and that they should be able to coordinate care with the specialists that are important, including people at the major medical centers who can be there for providing context and recommendations. So those are the take-home messages from what I presented. Thanks.
So, got one question, just asking for an opinion on treatment of patients with celiprolol. And if you want to expand on differences between celiprolol and other beta blockers.
So celiprolol came to attention in this community in 2010 with a publication in The Lancet, which had started with a group of 53 people who were being treated. Only some of them had had genetic testing, and they were all selected on clinical grounds. By the time everybody had been examined genetically, about 60% of the people actually had mutations in the COL3A1 gene. The summary evidence would suggest that the celiprolol made a difference, but the sizes of the group, the asymmetry of the treatment and non-treatment group, and the difficulty in determining whether the groups were equivalent really, I think, brought into question any of the conclusions from the paper. Now, the French group that had done that, on the basis of that, terminated the trial early, and then in the Paris Center, where the study was done, continued to treat all the people who had, or tried to treat all the people who had vascular EDS with celiprolol. And the end of that observational study was published in January of 2019, I think, in I can't remember where it was, but in one of the American cardiology journals. And it was a complex thing because it was really a natural history study of that group under the treatment of celiprolol. They used two dosing schedules, or ended up comparing two dosing schedules, one of 400 milligrams a day and the other 200 milligrams a day, to suggest that there were differences in the outcome. I think, again, there was no control group in the study, and so the conclusions drawn are difficult to put into context. Celiprolol is not available. It's not an FDA-approved drug. In the United States, it certainly can be available through Canadian pharmacies, and we have sometimes suggested that if people want to do this, and a number of people in the US have gone to France and have seen the group there. I think the evidence still remains difficult to interpret. We just don't know.
Thank you. That's very comprehensive. I think it's a question we all get, and very good to hear your opinion on. I think we're going to move on now to our next presenter, who is Dr. Shreen Shalhoub, also from the University of Washington, and who directs a large research effort looking at VEDS. So take it away.
Hi, good morning. Thank you for having me. It's a pleasure to be here. Can we go back to the earlier slide? I do have two slides because my topic was divided into two components. One was about the surgical interventions in vascular Ehlers-Danlos syndrome. And so through that talk, basically I went through the basic vascular surgery principles. And the bottom line is that there are no set criteria for people who have vascular EDS, predominantly because of the rarity of the disease. We have a lot of information from case reports, as well as each person's institutional experience. But the bottom line is what I talk to people about is that we have to weigh the risk versus benefit of the intervention. There are guidelines for aneurysms and dissections in terms of when to treat them, whether they're in the aortic or arterial bed. And the majority of people with vascular EDS, when we quote unquote operate on them, the majority of the interventions tend to be embolizations, meaning occluding the arteries. The next common thing that we do is medium-sized arteries are treated with stenting. So those are small stent grafts for the medium-sized arteries, and they seem to do quite well with that. And lastly, when you look at the aortic repairs, still the preferential treatment would be an open repair rather than endografts. The stent grafts for aortic repair in vascular EDS are still unproven. That said, I now have a group of people that I am following who have had these stent grafts placed prior to the diagnosis of vascular EDS, and so we're following them, and so that question remains to be seen. The bottom line is, I think, with modifying a surgeon's technique and being extra careful in knowing the diagnosis and treating people in a multidisciplinary team setting, surgical repair is feasible and it can be done safely, with the understanding that the risks for the patients are higher than the risk for the average person. And that's part of the counseling that we talk to them about. So we can go to the next slide. This was the other topic, was about patient engagement and research. And I think there's animation that's missing here, but thank you. So basically, these are the lessons learned from the Vascular EDS Collaborative. This was an effort that we started in 2017 to engage patients and to derive patient-centered research priorities. And here's the takeaway message is basically, we've been very successful with this community, and we've done a lot of work together. And it was very important to remember that you have to flatten the hierarchical structures early. You have to be mindful of the team's energy levels, and adjust the meetings accordingly. You do want to involve patient advocacy organizations early. We certainly involve the Ehlers-Danlos Society and the Marfan Foundation early on in this work that we've done. We've leveraged social media heavily to outreach to people and to also identify patients who are active in those platforms. And certainly branding is very important so that people know that this is what we're doing. We also use a lot of virtual meeting spaces. This is in the pre-COVID era, but this was necessary. Again, as you know, the disease is rare and people are all over the world. And then it's an iterative process. The diversity in the number of participants does increase over time. And lastly, just to remember that people, are very active in their own communities. And as a consequence, you can see that the VEDS movement has grown as well and has taken on its own, extension of all this work, great work that they're doing. So those are kind of the lessons. We've extrapolated a lot of these lessons also to the Aortic Dissection Collaborative, which is also ongoing now. So thank you.
If I can make just a comment, not about this, but for those of you who want to read about personal stories of people with vascular EDS, there's a publication that I was not aware of, but Kim, I think, and other people have pointed out in USA Today, which I think is today, by Tony Yasek about his experience with vascular EDS and in his family.
Thanks, Peter. That's really a neat article. I was able to look at it.
Yeah.
Have one question just on, briefly, can you comment on intracranial coiling in VEDS? Is that a good thing or bad?
So it depends on, again, the indications, right? So if and then this is neurosurgery territory, vascular surgeons, we operate from the neck down. Neck up is, base of the skull up is usually for the neurosurgeons. However, if the neurosurgeon believes that the size warrants repair because they're concerned about size criteria and that this is at risk for rupture, it can be done. One of the things, there's a classic article by Jim Black where he talked about how to do the exposure and the repair of the arteries, and certainly vascular surgeons can help with that. In the talk that I've recorded that's available on WUVA, I've put in pictures of how we do the exposure and the repair of the femoral arteries to facilitate access. And I think that's really important to avoid iatrogenic injuries that are unrelated to the primary operation, and to make that an operation success. So I think it's worth discussion on a case basis. The other component of that is also to look at the genotype. We do know that by genotype, the tissue quality does vary. So for example, people who have haploinsufficiency or null mutations, their quality of tissue tends to be better than people who have, for example, exon skip variants or splice site variants. And so that's also part of that discussion in terms of risk stratification prior to surgery.
One of the places where coiling has actually been used extensively as anything is in the carotid cavernous sinus fistulas to try to occlude the area. And stents have sometimes been used or tried to be used, but the most common approach, whether it's venous or arterial, has been to try and occlude the fistula by coiling, and it's been at least moderately successful.
I have a question for Dr. Shalhoub. What is your current practice regarding surveillance imaging, post? There's obviously huge practice variation even across experts. So
I agree, there's huge practice variation. I would say when I started doing this about 8 years ago, one of the myths was that, well, there's no point in surveilling because what's the point? You're not going to operate. And I don't agree with that. I mean, I definitely start with, head to pelvis imaging when I first meet somebody, they're brand new to us. And then subsequently, if there are no pathologies, then I will switch them to duplex ultrasound, where I duplex their mesenterics, renals, iliacs, and abdominal aorta. Because predominantly the aortic pathology tends to occur in the abdominal aortic portion. Less common, or the next less common, more, following that, you can see some aortic root dilation, but it's not that many people in general. So I'll switch them to duplex ultrasound. If they have pathology, then I will re-image in 6 months just to ascertain to see if there's any evidence of growth. And then, subsequently, probably another 6 months. If they're stable, then we'll go back to annually. If they're growing, then we'll start having discussions about risk and benefit of repair.
thanks so much. I think we're out of time for questions, and I'm going to turn it back over to Dr. Eagle.
Thank you, Mark. And thank you, Shireen and Peter, for really, really nice presentations. There's also a testimonial video in HUVA. I believe it was Christy Poseval on EDS, which I found really powerful. So I recommend that you see that. So now we're going to move into the next phase of our session, and it's going to be on bicuspid aortopathy and related valve disease. And we have both Simon Bodie and I believe Reed Piritz to moderate that. I'll turn it over to you, Simon.
All right, I'm just unmuting my audio. So Reed and I will be co-moderating this session. We think it's a very timely and important session because of the frequency of bicuspid aortic valve and the ability to look at these patients sometime in advance. So without further ado, Siddharth Prakash will be giving the first talk. Siddharth is Associate Professor in the Department of Internal Medicine at UT Houston. His research work primarily is in the BAV of young patients and those with Turner syndrome. He's also chair of the GenTAC Biospecimens and Data Working Group. Thank you very much, Siddharth.
I'm not seeing Siddharth.
Nor am I. Now
Bruno, can you help him get in?
He is here. Siddharth, if you can unmute, you'll be able to speak.
And turn your video on so we can see your charming face.
I know he was having some internet communication issues before. Maybe what we would do is move on to the next talk and then come back to him. Okay. Let's do that.
Reed, you're introducing Tor, I think.
Reed, you're on mute. You have to unmute yourself. Okay, there you go.
Good. Well, it's a pleasure to have Tor Sant here to talk about his work on dealing with BAV patients. And once I hear his conclusions, I'll try to apply them to myself. Tor?
Well, my goodness.
I appreciate the invitation to speak at this, and I'm a little intimidated by the caliber of the science that's been presented before me, and I'm sure will follow. But so Kim said he's a simple population scientist. I'm a simple clinical surgeon. So I've had interest, of course, in this condition for quite some years, and have struggled with the item number one, which is the threshold for intervention, and have gone up and down with that myself. And I think that where we are as a cardiovascular community in terms of trying to set that threshold has swung a bit like a pendulum. I do think that there's growing acceptance that the threshold for intervention should be no different for bicuspid than tri-leaflet valves. Now, having said that, of course, the concerns are that, for one, so often the aortic dilatation that's observed is seen in such young patients. We're worried about the period of time that they have to at risk, and are also emboldened a bit by the low risk that they present, and the potential for progressive enlargement of the aorta over time. But I think that the pendulum has swung back a bit, and there's some evidence that was presented at the AATS meeting by John Eleftheriades that was supportive of this notion that perhaps the threshold should be no different for bicuspid than tricuspid valves, maybe even a higher threshold. And of course, all of this is colored by the fact that we're trying to make a binary decision on the base about a continuous variable. Second point is, I think, growing acceptance that we don't need to be overly aggressive with the root or arch. I've said before in the past, this isn't cancer. We don't have to have clear margins. I think the implication for the distal extent of resection is that not everyone need be subjected to hypothermic circulatory arrest, and prolonged bypass times perhaps associated with that. That may sound trivial to the surgeons that are on this call, or to the physicians that are on this call, but given the prevalence of bicuspid aortic valve disease in the community, when we make a recommendation about doing these things under circulatory arrest, a lot of these patients are going to get their surgery done at low volume centers. And I think that it's incumbent upon us to try and convey the safest and most prudent approach to that. Similarly, with aortic root replacement, again, individuals like the surgeons that are on this call do root replacements all the time. I don't think we take it for granted. None of us take any of this for granted. But we also, I think, if we're in quaternary care facilities, pretty regularly have patients referred in from other sites with catastrophic results of aortic root replacements. So I again think that we should be circumspect about that, and it's not cancer. And then the third, and Craig had some comments related to this earlier about the approach to the valve. I don't think there's a perfect approach to the bicuspid valve, the regurgitant bicuspid valve. Repair is imperfect. Perhaps the results are improving. I think if you're depends on whether you're a half full, half empty, or an engineer that just thinks that the glass was made two times too big. Repair is something that we as surgeons like to think about and talk about, but we still see failures. Biological valves continue to have limited durability, although the newest versions, the dry mounted valves, are meant to last longer, but here's hoping that they don't turn out to be like the Sorin valves that we seem to be taking out every day. And finally, of course, that mechanical valves may require less, but still some warfarin, and we're stuck with that. So to state, I guess, the obvious, there's no perfect approach to the bicuspid valve, and that, I think, has to color our approach to how aggressive we are in intervening on the aorta in the presence of a bicuspid valve.
Thank you very much, Thor. I'm not seeing any open questions. Is anyone else aware of any? If not, let me pose a couple of issues for Tor to comment on. One is, to what extent do you think the age of the patient should be factored into the indication for surgery on the ascending aorta?
Well, I think that what we know about thoracic aortic aneurysmal disease in general is that advanced age is a risk factor for aortic dissection, and certainly the work that Jun Boom Kim did here with our thoracic aortic database showed that the risk of rupture or dissection goes up with age. So the young person with a moderately dilated aorta who doesn't have hypertension and has a well-functioning bicuspid valve, I think that we should watch those people more closely. I'm actually more aggressive with it the older the patient is, or if they've got hypertension, or if they're a smoker, of course.
Thank you. If we have time, one more quick question, and that is, given your comments on the potential failure of bioprosthetic valves, what do you think about using the largest annulus possible so that if the valve does fail, that a transcatheter aortic valve replacement could be performed?
Yeah. So, well, for one thing, in the presence of a bicuspid valve, usually the annulus is enlarged, so it becomes less of an issue. Number one. Number two, the valve-in-valve procedures, certainly they're very popular right now. Where we're going to land with that in the long run, I don't know. Having reoperated on a number of patients with valve-in-valve, it's a pretty messy situation. I am concerned actually about the long-term risk of infection in patients with that. There's a lot of junk that's tucked in there behind the stent. I don't want to sound like a Luddite. I'm delighted if it turns out to be a great solution, but I think that I spent 10 years in Missouri, so you're going to have to show me.
All right. Well, Siddhartha's back, so let me reintroduce him. His research work, he's at UT Houston. His research work is in the BAV of young patients and those with Turner syndrome, and he's also chair of the GenTAC Biospecimens and Data Working Group. Siddharth, all yours.
Thank you. My apologies. I would like to review what is currently known about the genetic basis of BAV and go over some recent results in our laboratory. We know from genetic analysis of patients with rare variants and families with inherited disease that BAV, as in hereditary aortopathies, is inherited as an autosomal dominant trait in most circumstances, but with considerably reduced penetrance and variable expressivity. That is, many individuals who inherit variants that are linked to BAV also have other cardiac defects and may have variable age of onset and variable manifestations of their disease. This has made it extremely challenging to identify new BAV genetic loci. However, we have been able over the past 5 to 10 years to develop a substantial panel of genes that are recurrently mutated in BAV patients. And I've summarized the state of the current knowledge here. On the bottom, you can see that there are genetic syndromes associated with bicuspid aortic valve. Turner syndrome is the most, as you've heard, is the most significantly associated genetic syndrome with BAV, occurring in a substantial proportion of women with Turner syndrome. And the genes for these are believed to be really multiple genes on the X chromosome with reduced dosage that confer susceptibility but are not strictly necessary individually for bicuspid aortic valve formation. Also, mutations of the developmental transcription factor TBX1 on chromosome 22 related to large genomic deletions in velocardiofacial syndrome cause BAV. And as we've heard, Loeys-Dietz syndrome, characterized by various TGF-beta receptor and ligand mutations, as well as SMAD3 mutations, are associated with an increased prevalence of BAV, although lower than in the previous two syndromes. In addition to that, we know that there are several non-syndromic genes that are mutated in patients who do not show syndromic features. These include Notch1 and the GATA transcription factors. that are linked to cell fate in the developing left ventricular outflow tract. And they're also more recently been linked to aberrations in a developmental process known as endocardial mesenchymal transition, or EMT. This is a recapitulated process that is required for many aspects of normal development, but it's also reactivated pathologically in disease states. And determining the likely targets of these aberrant signaling pathways could be important to develop therapies for BAV disease. We also know that mutations of TGF-beta and BMP signaling pathways are abnormal in many BAV patients, and there are patients with loss of function mutations in SMAD4 and SMAD6 who have BAV in association with various systemic features. Finally, recently described mutation in ROBO4. ROBO4 is a gene that's developmentally expressed in genes that are in cells that are migrating into the left ventricular outflow tract and are responsible for aortic valve remodeling. So this indicates that cell migration defects into the pharyngeal arches and left ventricular outflow tract primordia can also lead to BAV formation. And the reason for this is that in the endocardial cushions in the outflow tract, the endocardial cells receive cues from the underlying myocardium, but also from flow in the outflow tract itself from the beating embryonic heart. This triggers them to undergo EMT, migrate into the developing valve tissue, and ultimately remodel the valve into elongating leaflets. Related to this, our lab has found a series of recurrent mutations in mechanosensory genes that regulate this process, not only in Notch1 itself, which is itself a mechanoreceptor that can be cleaved and go into the nucleus to regulate cell fate decisions, but also in a network of genes that sense flow and shear stress on the cell surface, and then can transduce those signals to Notch1 activation or modulation. So we think that ultimately BAV cases are caused by rare variants in this network of genes that perturb cardiac development by either desensitizing or dysregulating the process by which cells enter and migrate into the developing valves. So I'll take some questions.
Very good. Dr. Gleason has asked a question: despite the identification of some mutations identified in some BAV patients, are you convinced these alterations are causal in the disease states, i.e. especially valve and aortopathy? Thus, do they have implications in diagnosis and or treatment? A two-part question. Thank you.
Great. So recently we looked at this question of whether or not genes that cause valve defects are linked to the same genes that cause aortopathy, because so many BAV patients do present with aneurysmal disease. What we did was to compare patients that have an identical phenotype, BAV and aneurysms, but were ascertained for different reasons, either predominantly due to an aneurysm or dissection, or predominantly due to valve disease requiring valve intervention. What we found was that even though the patients were of the same age, were matched for other cardiovascular risk factors, we only found these panel of BAV mutated genes in the patients who were ascertained for valve problems, not for the patients who were ascertained due to aortopathy, suggesting that these two populations, while phenotypically similar, are genetically distinct. And we think that this has important implications for management based on the mutated gene.
Very good. Since there are, excuse me, no other questions for Siddharth, I'd like to move on, but we have several questions for Dr. Sunt that came in just after his talk had finished. I propose that we do those at some of those at the end, excuse me, if we have time. I hope you don't mind. Kim, is that okay?
What I would suggest to you, Simon, is that we will ask the speakers to answer these questions virtually in the next few days, and we will send around a transcript of the Q&A so that everybody can catch the richest of those interactions.
Excellent. Thank you. So the next speaker is Dr. Richard Devereaux from Weill Cornell and Columbia Presbyterian. His talk today is entitled Medical Treatment and Follow-up in BAV. Dr. Devereaux is particularly interested in arterial and valvular phenotypes in Marfan's and has and its treatment implications. He's also a member of the GenTAC Clinical Science Working Group. Thank you, Dick.
Okay, can you hear me?
Yes.
Okay, great. Thank you very much. This is, let me see, something is echoing. My speakers are off here, but something else is echoing. Anyway, the medical treatment and follow-up of BAV patients is based on considerable experience, but not really on the sort of evidence-based clinical trials or large epidemiological studies that we look for other types of evidence-based practice. The starting point in patients with known BAV or a family history of BAV includes imaging of the aorta from the root through the arch, including the area of coarctations at baseline and intervals thereafter, depending on findings. If the aorta is normal in size, then perhaps 5 years, shorter intervals, the larger the aorta is, or the more severe valvular disease is. Echo is the workhorse, being most widely available and easiest to use in many settings, with magnetic resonance imaging and computed tomographic angiography being of great value. Obviously, if there's any acute syndrome where dissection might be possible, then a CTA with its ability to detect extravasation of dye is the imaging modality of choice. Control of blood pressure to normal levels is always indicated, and obviously with the redefinitions of hypertension, going to systolic pressures under 130 or even 120 are now increasingly in vogue for prevention of hypertensive complications in the general population. Many, I suspect most of those in the audience here, treat to lower targets and heavily rely on beta blockers or angiotensin receptor blockers, by analogy with the larger amount of experience available in Marfan patients. One point I would make about a previous discussion in terms of various ARBs, the irbesartan is approved to a dose that's the equivalent of about 175 milligrams of losartan. So I have some patients on irbesartan and others on 150 or 200 milligrams of losartan to get to the same level of effectiveness. I don't know if any of that for Marfan patients applies to BAV patients, because the rate of progression of aortic disease is too slow to be testable in therapeutic trials of fundable size. The pregnancy guidelines are similar to other non-syndromic aortopathies. European guidelines recommend against pregnancy if the aorta's an aortic segment is 5 centimeters or more, which seems sensible, and obviously close intra-pregnancy follow-up by cardiologists and high-risk obstetricians familiar with aortopathies are important. Beta blockers may commonly be used. And there's also a number of studies that have been coming out suggesting that patients with bicuspid aortic valves are at high risk of both the likelihood of getting infective endocarditis and of suffering severe complications, so that they fall closer to some of the lower risk congenital conditions than to garden variety mitral valve prolapse, which may also be, when it's complicated by significant regurgitation, a high risk lesion. So that while current guidelines recommend against infective endocarditis prophylaxis for most, if not all, bicuspid valve patients, I suspect this deserves reconsideration in the next round of US and UK guidelines and presumably others. Okay, thank you very much for the opportunity to present both for these minutes and in the larger presentation that's online, and I'd be delighted to answer any questions.
Thank you very much, Dick. There will be some questions which we encourage you to answer virtually in the next few days. We're fortunate, last but not least, to have the opportunity for Len Girardi to present. He was not able to present earlier. So Len, please take it away.
Thank you very much. Bruno had recorded a session for me, but I can share my screen and bring up my slides if that sounds okay, or how should I do that?
Let's just deal with your take-home messages.
Great. So I think the question is really in chronic aneurysms is sort of when to operate. And it's not so much a chronic aortic aneurysm because they're really treated the same, whether it's somebody you've been following for years or somebody who just came to your office that had a CAT scan, perhaps for symptoms, but maybe for some other reason, lung cancer screening, calcium screening for coronary disease, et cetera. The indications to operate are pretty much the same. And at least in current guidelines, which are the 2010 ACC and AATS guidelines, and then the 2014 European Society guidelines, the majority of the indications are based upon aortic diameter. And almost irrespective of etiology, with a few exceptions, of course, being some of the patients with connective tissue disorders and family histories and sort of bad genetics. But majority of the indications are based on measurements and diameter. In particular, for most aneurysms, 5.5 centimeters, as Tor had alluded to, remains the gold standard number that we use to determine the need for intervention. But as we know from IRAD and some of the other studies, this is an imperfect science. And there are significant numbers, upwards of 60% of patients who present with type A aortic dissections at diameters substantially less than current guidelines would indicate the need to proceed. So how do we do a better job of identifying those patients to avoid catastrophic events like a type A dissection? Now, there are a lot of other metrics out there currently that are being looked at, and there's only one in the guidelines that has been mentioned and seems to be something that you can hang your hat on, although again in a very small number of patients, and that is the aortic area to body surface area ratio that was originally described by Lars Svensson. And admittedly it was in a very small population of Marfan patients, only 21, 9 of whom presented with type A dissections, and a majority of them had exceeded that threshold of 10 centimeters per meter squared. So I think that's the only other measurement that's mentioned in the guidelines, but right now we're looking at things like aortic size index, aortic height index, aortic length. And I think of all of those, length seems to be more promising at the time, and we'll see how it plays out, because again, it's a relatively new measurement. Once again, these are things that will require a lot of investigation. We really don't have large series, large numbers, and certainly no randomized trials comparing one versus another. So lots of work needs to be done to get a better handle on metrics that are really applicable across a wide range of patients. And that includes those with bicuspid valves. The other thing to keep in the equation as far as when to operate is really the outcomes of surgery, because really the decision to operate is based on risk and benefit. And as was mentioned again by Tor, was that across the country, there's still a 4 or 5% risk of mortality for elective aortic root surgery. Slightly more for patients with aortic stenosis than aortic insufficiency, but nonetheless, a mortality rate that is not insignificant and definitely has to be factored in, particularly as there are a lot of patients who will have surgery outside of what we would call aortic centers of excellence. In the hands, though, of those with significant experience, the rate for elective surgery is substantially less than 1% for most elective patients, irrespective of the underlying valve pathology, bicuspid, trileaflet, stenosis, insufficiency, mixed. And so that also factors into the equation and is really something that those that argue for lower thresholds also use to try to move the needle guidelines. Lots of work still needs to be done. We need to do better at getting better results across a broader range of surgical centers and experience, so that patients who aren't fortunate enough to be in an aortic center of excellence can still expect a great outcome. So lots of work to be done, but I think it's a fertile area for investigation, and we're happy to be part of it. So thank you.
Thank you, Len. Again, any outstanding questions, we encourage you to answer virtually. We're going to move on, but I want it to be noted that this session moderated by Simon and me is the only one to have finished within the allotted time. Kim, take it away.
Reed, you stay competitive even even now, which we love. And your testimonial, by the way, was absolutely magnificent. So those of you on the call who have not seen Reed's personal testimony about going through bicuspid valve and aortopathy surgery, please do. It's very compelling. And Len, thank you for adjusting your calendar with the EX meeting and stuff to be able to present that for us. We really appreciate it. And your support of the Alliance has been very important as well. So this last session before we close is actually meant to just be an update for all of you, kind of a rapid fire update on some of the key registries and research collaboratives that are ongoing. One of the goals of the Alliance is to connect scientists and clinicians around the world and to try to make sure that we're working as much together as we can to synergize all of the efforts. I love this term, teamwork is dream work, and we're dreaming of a better state for our patients, and that happens when we have collaborative science. So we're gonna ask the speakers, they have 3 minutes each, no more than 3 slides. We will ask you to pose your questions virtually. We will not take questions during this presentation. It'll be rapid fire, but we will get those questions answers to you in the next few weeks. All right, so here we go. Oh yeah, Kim Eagle is first with IRAD. Can I have the next slide? So IRAD is now 25 years old. These are the 59 centers around the world that are currently collaborating to try to understand acute aortic dissection and its various ramifications. And the next slide shows you where we're at in terms of enrollment. Almost 10,600 patients are now in the registry, and about 70%, 68% have type A, and the rest type B. A few years ago, to improve the granularity of the data on surgical therapy and interventional therapy and things like cannulation and support, we added a separate questionnaire which has 200 variables. That's the interventional cohort, and they've grown to be now over 4,000 subjects. So IRAD continues to grow, and I think we're learning new things, and also we're able to measure how we're doing as we compare to therapy to the past. The next slide just lists the last 5 papers from IRAD, and I'm really excited. The first paper is coming out next week, this first list by Ellen Braverman, and it's on the pregnancy data and aortic dissection. And this will be a historic moment for IRAD. It will be the 100th published manuscript from the group in the 26th year of our operation, and almost 11,000 patients in the registry. So the IRAD investigators continue to work together to try to push the boundaries in aortic dissection. So next I'm going to introduce Diana Milowitz, who's going to give you a quick update of Montalcino. Diana?
Yeah, thank you very much, Kim. We took your what you did with IRAD and started the Montalcino Aortic Consortium. The mission is to collect clinical data on patients that have mutations in all these different heritable thoracic aortic disease genes so that we can define the optimal clinical management for those patients. I want to thank the steering committee members, all shown in red here, and then all of the groups that have joined the consortium worldwide. We basically have sites at every country that does genetic testing. And we're very thankful to the Timrity Family Foundation, GATA, and the JRF for providing funding. We're still open to people joining MAC. You can join two ways. You can start the protocol at your site and enter data on your patients at your site, and then transfer it to us either identified or de-identified, depending on your choice and your IRB's choice. Or you can take patients that you see in your clinic and refer them to us, and we can recruit them into MAC in Houston. And so if you have patients from MAC, just go ahead and email jrrp.research@uthtmc.edu. So we've got over 1,000 patients now in MAC. We have excluded initially FBN1 patients and COL3A1 patients, and really are focusing on the novel HTAD genes in terms of defining the phenotype. We have out a number of publications, and just a few notes from those publications. We published data on dissections in myosin light chain kinase patients. And those patients often dissect with no enlargement of the aorta. So when we look at risk for type A dissection over time, there is no risk for a dissection up to 40 years of age. And then suddenly the risk of dissection goes up from there. So we're recommending for myosin light chain kinase, not even to consider aortic size, but instead to consider the age of the patient and the risk for type A dissection. And so that's an example of some of the data coming out. Now we've put all the data together and begun to look at comparing all the different genes. And I'm just going to show you this one slide of some data. Can you go back, please? One side of some of the data coming out of MAC, and this paper is ready for submission, so be looking out for it. This is the first 1,000 patients with mutations in 7 genes that are listed here below. These are those Loeys-Dietz syndrome genes. The ones on the right are the smooth muscle contractile genes. And what is graphed is the age of an aortic event described as surgical repair of an aneurysm or presentation with a type A or B dissection, and how many people at that given age have had that event, the cumulative risk. And so if you can see on the left, these are all those LDS genes. And if we look statistically across the genes, there is a significant difference in the age of onset. So there's significant differences between the LDS genes, with TGFBR2 having the earliest onset disease and SMAD3 having the latest onset disease. And also, if you look at the very beginning of the curve, you can see that there's only 2 genes that really have any events in childhood. That's TGFBR1 and 2. Whereas with SMAD3, the green line, there's no onset of aortic events until well into their 20s to 30s. So these really have major implications in terms of managing these genes. And I urge you, is going forward, that if you report LDS, please make to either a patient or in a publication to report which gene it is and which specific variant it is. Because we need that information, because there are differences in the aortic disease presentations. There are differences in the risk for dissection with minimal enlargement. For example, we've just published a year ago that patients with SMAD3 are the average size of the aortic root at the time of dissection was 54 millimeters, with only 3 patients out of a group of about a dozen that we had accurate measurements prior to the dissection, only 3 patients dissecting under 5 centimeters. So that's different than our published data on TGFBR1 and 2. So going forward, we really have to distinguish to the patients in our publication which of those LDS genes the reported cases have. And then on the right, you can see there's dramatic differences between the age of onset with ACTA2, myosin light chain kinase, and PRKG1. The myosin light chain kinase is in orange, and that's all events. But if you look at just type A dissections, they don't start until the patients are in their 40s. The earliest age of onset of any of these genes is not TGF-br2, but rather PRKG1. And these patients have a very strange presentation where they have type A and type B dissections early with no enlargement. And if they don't dissect, they have slowly growing aneurysms as they get older. So for those patients, we're really emphasizing that whether or not their aorta is enlarged, they need to be on some blood pressure medicine, and we're recommending beta blockers because one patient got switched from beta blockers to losartan and had a dissection 3 months later, once again, age of 19, with no enlargement of his aorta. So based on that limited data, we're really pushing beta blockers in those patients. So this is just a snapshot of the data that's coming out of the MAC consortium. And I think that it all has implications for how we manage our patients. And we really think these data say that we, instead of grouping patients together under syndromic names, that we need to be grouping them based on the underlying gene, and in many cases on the underlying variant in the gene. The treatment, I just got an invitation to serve on the updated treatment guidelines, and we will be pushing the gene-specific management as part of those treatment guidelines. And in the future, hope to have some way that busy physicians could quickly access all the published data so that they know how to manage that patient in their clinic or in their surgical program. So thank you.
Diana, thank you very much. This is really a great example of science to bedside in reality, and it's a huge advance for us. You were very strategic, not only in putting the collaborative together, but in placing the meetings in wine's top, Italy's top wine growing area, weren't you?
Well, that's thanks to the Timordi family in Gatta.
So yeah, so Brunello and Montalcino kind of go together, so I can't wait for the next meeting. We need the pandemic to end. So thank you very much. And now a quick update on BavCon by Simon Body. Simon.
My apologies. I've muted myself. A very quick update. This data from Hector Michelena is now, I think, 12 years old. It still mirrors the current experience where folks with a bicuspid aortic valve go on to have a lifetime risk of around 50 to 60% of needing an aortic valve replacement, and about a 20% risk of having an aortic aneurysm or dissection that needs surgery as well. So just to emphasize its overall importance. And then for the next slide, please. We're currently working on a genetic study, the genetics of BAV itself, the genetic causes of aortic stenosis in people with a BAV. So that's not BAV versus TAV stenosis. That's BAV stenosis versus no BAV no stenosis. And then a similar study for aortopathy in people with a BAV. That group has enrolled about 6,000 patients with a bicuspid aortic valve, and we will be having the genotyping data back in the next month. I know I've said that for the last 4 months, but it really looks like it's true now. And we've also done considerable work on the epidemiology. As Reed mentioned a few minutes ago, is the bicuspid valve prone to SBE? Our work showed it was about 20 times more likely. Some interesting work on when to operate on the dilated aorta in a patient with BAV, and then more work coming up. Does the bicuspid aorta continue to dilate after an AVR, and how much more AS does a BAV have? We think that there's a mortality burden of BAV somewhere in the 60 to 70-year-old range, but prior to that, there is not a mortality burden. And then finally, the next slide, just to list those folks, the top 2 or 3 investigators at each site. I should have used a smaller font and put more people in here. I apologize. We have 17 sites contributing those 2.5 6,500 patients, with a total of about 65 investigators. One of the most important has been GenTAC, which has kindly contributed of around 750 patients with BAV who had aortic aneurysm, and that's going to be a very large portion of our hypothesis 3 data. So we're particularly grateful to Kim and everyone else in GenTAC for your kindness in sharing those data. And we're currently genotyping about, we've done about 250 of the GenTAC patients, and we've just received samples kindly given to us by Siddharth from the GenTAC patients, and they'll be genotyped in the next couple of weeks. Thank you very much.
Thank you, Simon. Such a good example of how rare diseases require very large efforts to create databases from which we can glean both hypotheses and then validation sets. And BavCon continues to inform, and we're very delighted that GenTAC has been a part of that. Now we're going to hear from Shireen and an update on the VEDS Collaborative. Shireen?
Thank you. So as you've heard before, we've started this effort in late 2017, and there's two things that have come out of this. One, go back to the earlier slide, please. One is that we've created thank you. One is that we have the Research Collaborative Study, which is a longitudinal natural history study. To date, we've enrolled 209 people. We're leveraging community-based enrollment. This is all virtual enrollment and electronically done, so people don't have to travel. The data from that is available to any other collaborator who's interested in looking at a specific topic. We can abstract the data for them and work collaboratively as well to answer some of these questions. All these folks have their genotypes are noted there, as well as we're collecting their imaging. So over time, this will grow to be a very robust data set to answer a lot of the questions we've been challenged with. The other thing is we've submitted a trial called Meds for VEDS, which is a comparative effectiveness trial on medications that are currently used in vascular ADS, so stay tuned. That's submitted to PCORI, Patient-Centered Outcomes Research Institute. Okay, next slide. Additional engagement work that we have funding for now is specifically to look at people with aortic dissection and at risk for aortic dissections. And this is, again, community participation. And the goal is to, again, similar to VEDS Collaborative, we are training the individuals who are participating, the patients, on the elements of research, as well as working with researchers, and so that we can all grow as a community that is definitely patient-centered. And so anybody who is interested in being a stakeholder in this group, we are actively doing this work now. So you're welcome to participate, and the commitment is a once-a-month meeting where we appreciate your participation with the patients and with the rest of the researchers. So thank you.
Shireen, thank you very much. I'm so excited that the VEDS effort is part of the Marfan Foundation now. That's a wonderful partnership. And your work with this PCORI network really is going to inform a lot about what patients understand, what they don't understand, what can we do better in terms of how we both treat and manage and educate patients and families with these types of disorders. So excited about that and looking forward to the next steps. Now I'd like to turn it over to Cheryl, who's going to talk to us about the current work in the Turner Collaborative. Cheryl.
Sorry, Kim. Cheryl asked me to give this talk. This is Mike Silverbach.
I'm delighted you are. Thank you.
So I only have one slide, and I'll jump off on a couple of points here. Continuing the theme of patient-centered and patient participation in research, I'm the chairman of the Turner Syndrome Research Registry, which is a participant-powered registry. This is the cover of a special issue of the American Journal of Medical Genetics that we published last year. It has about 24 papers. Many of them are primary research and reviews. And we're really highlighting the function of our registry. And the idea here is that the main driver of research needs to be the rare disease group, and that's why that's the largest gear, and that there has to be a close relationship with the Turner Syndrome research community, which we have cultivated over 3 symposiums over the last 6 years. The idea here that I think I was learned from the experience of GenTAC was that often research materials out of a registry went off to researchers. They would gain a lot of information and it would not return to the registry. And it gave me the idea that in order to move research forward, there had to be a reciprocal relationship between the delivery of materials, blood, DNA, images, and essentially a bargain with the researchers that we would provide those materials, and in return, selected information would come back and enhance the registry, hence the use of the term a virtuous cycle that is created. And I should say this is a bit of a departure from the other registries that we're talking about, because the fact is Turner syndrome is not a disease. It's a condition that is associated with a number of common diseases. And it's a whole variety of diseases, and that's represented by this gear here, which, as you know, congenital heart disease is a major one, but also infertility, attention deficit disorders, metabolic syndrome, hearing loss, etc. But they're all driven by the basic idea that is, I think, engendered in Cheryl and my work, that X chromosome dosage interacts with the autosome to increase or decrease the risk for a variety of diseases. Right now, we've got over 1,000 individuals in our registry, and we're kickstarting this notion of a virtuous cycle by using data that Sharon and I gathered with the assistance of GenTAC, in which we collected 180 whole exomes. We have now consented nearly all of those individuals with whole exome to include that whole exome data in the registry as sort of a spark plug to encourage the research communities to utilize that whole exome data, with the understanding that the results that comes out of that data, including new genetic information, will redound into the registry and hence attract more researchers into the Turner syndrome community. I think this is a unique model, and I think as we move forward, it may become a standard for how rare disease research can occur. I should say we have been using this within the Peer Genetic Alliance platform, and we're in the process of transferring this to a REDCap system that is more under the control of the Turner Syndrome Society itself. So I'd be happy to take any questions, and thank you for allowing me to present this information.
Thank you, Michael. We're going to have our participants post questions virtually, and then we will send those to you. And I can't thank you enough. I've always viewed you and Cheryl as sort of like Batwoman and Robin in a way, the dynamic duo pushing the basic and translational and then the clinical. And, you know, your leadership has transformed, I think, a national effort, if not international. And working with both of you over the last 14 years has been such a pleasure. And now in the Alliance, we will continue and hopefully leverage even more. And this network looks to be a great advance in terms of going quickly into a future state. So thank you very much. Now, as you know, the GenTAC Alliance is an international effort. And there is a wonderful network that's been formed in Europe. And we've asked Guillaume Jandot to update us on the European Vascular Network.
Thank you for the invitation and for the possibility to tell you what is VASCURN and VASCURN Registry. Next slide, please. So VASCURN is a vascular European reference network, which means this is a network which has been funded by the EU to take care of patients with rare vascular diseases. So at present, there are 35 expert teams from 30 different hospitals, from 17 member states, European member states, and there are also patient organizations which are participating, 70 patient organizations. We are in the process of growing, and there is new centers which are coming into the network, and we are trying to have more countries represented in VASCURN. Next slide. So we have an action plan which is made of different points, and this action plan you see can include the registries, and the registries will be organized as is VASCURN, and you see on the left of the slide that we have 5 rare disease working group, which are a group of diseases with vascular involvement, rare diseases, and on the top you have the heritable thoracic aortic diseases, HTAD working group, with the chair is Julie de Backer and I am a co-chair. We are meeting between ourselves every month. And next slide. We have also participation, systematic participation of patients who are participating in every activity of the network. And we have some transversal working group, including registry working group. Next slide. So the registry will be organized because it's not out yet with a core data set, which is the minimum data set, which will be common to all the rare diseases that we take care of, lymphatic, HTAD, medium-sized artery, which is Ehlers-Danlos syndrome, HHT, and different vascular anomalies, and also common to other rare diseases to be able to make epidemiologic study. And then on top of that, we will have some additional items which will be added depending on the disease. And the ones that we are using for the HTAD are based on the French registry and are made identical or compatible with those of the Montalcino Aortic Consortium, because we are many centers already participating in the MAC studies. The different vascular members will include the patients and all the data and the metadata of the data, which means what type of items is registered and in which format will be made available to everyone on the European platform on rare disease registration. And the base of the registry will be to be fair, which means findable, accessible, interoperable, and reusable, meaning that it will be easy to use for everyone. And if you want to know more about VASCURN, you could go on the VASCURN website, vascurn.eu for Europe. Thank you for the invitation and thank you for listening.
Thank you, Guillaume. Really appreciate your presentation. This network is going to be so critical to pushing the boundaries in our understanding, and we're looking for ways that we can try to collaborate even more fully as the various registries and individual laboratories proceed along their journey. So we've covered a lot of ground today, and it's the first virtual meeting of the GenTAC group. We've tried very hard to create a format that would allow us to cover the scientific waterfront in a fairly brief time. I certainly apologize for time constraints because all of the presentations were great. We'll send a survey around to you asking for your thoughts about ways that we can improve the next meeting. Also, if you have thoughts about topics or other speakers, please give us that. Oh gosh, yes, there's one more collaborative I forgot. I'm getting too old. Shane. Is Shane?
Yes, I'm on.
Talk
No
about
worries.
clarity. I had a TIA.
No worries at all. So I know it wasn't on the original agenda, so we added it later, but thanks for I'll be really quick. But for those, many of you already know about this, but we've created a pediatric registry, and it's to focus on the care of young children affected by genetically mediated aortic conditions, and also to really focus on the longitudinal imaging to try to draw information from that. We really struggle, people who take care of children, because all of the guidelines basically exclude children because there's very little data in children, evidence-based data. There are single center papers that suggest recommendations, but again, it's not based on data, and there's a large group of us that are really interested in getting more pediatric data out there, and so that we don't need to use adult guidelines. If you can advance. So, keep going. So the plan is to actually collect retrospective longitudinal clinical and imaging data from as many sites as possible. We have 29 sites now signed on. This goes up to age 30, and we're looking at outcomes for surgery, dissection, and death. And the vision is that this continues as a living registry so that we can keep doing it. We've proposed an R01 that gets graded in a couple of weeks. And we've proposed 3 questions, which I'll talk about in a sec, but the goal is that all these centers can continue to ask questions from this registry, whether from all aspects of science that are focused on children. And so I am co-PI on this with Shelby Cuddy, who is the chief of cardiology at Johns Hopkins and who is a MRI expert, and he has a center for artificial intelligence. We have collaborators from all over. You can see here many people on this call. Haldees is a co-I, as is Shireen, for bringing us the VEDS knowledge. Our aim too is specifically around VEDS, and Justin Wigan, who's an MRI pediatric specialist as well. So we're really fortunate. We'd love to have more centers, even if you're an adult center and have young adults under 30. We'd love to have as many as possible. If we can go to the next slide. Just talking about our first 3 aims. The first 2 aims are doing a microsimulation project. The first is in Loeys-Dietz and Marfan syndrome. The second is in vascular EDS, but we're using Monte Carlo modeling and microsimulation to put in clinical inputs and imaging inputs, but specific imaging inputs like aortic size, dissection, and modeling these on a yearly basis. So someone could put in 5 or 10 inputs and have the risk of dissection by Bayesian methods at the end. And so those are our first 2 aims. And our third aim is using aortic imaging, CT and MRI from all of these to help predict dissection. And this is using multimodal deep learning algorithms, which are within the AI sphere. So we're excited about it. I know that was very brief, but just email me if you would like to collaborate.
Thank you, Shane. So wonderful to see a registry form focused on children who have often been left out of certainly the more clinical registries that we've had so far. So this is a huge advance.
Oh, and one thing, our fields all align with MAC. And so centers that are already contributing to MAC, they align. We just have more imaging fields. So.
Awesome. Well, I want to thank, especially I want to thank Joe Grima and Marion Hoffman-Bowman, who co-directed this summit meeting. I'd really like to thank the 5 patients who gave absolutely wonderful testimonials. The speakers were terrific, and their plenary addresses are available to you as well as the summary slides. We had, I think, 35 abstracts that were excellent, and 8 of them had a virtual poster presentation on Thursday night. I really want to thank the Marfan Foundation operational team, Bruno DeSalva, Kelly Koplish, Helene Sharuk, Eileen Micheli, Michael Weimer, and Joe Grima. They're the people that made this meeting happen, and working with them these last few months on this has been a true pleasure. I think that we see in full view the power of collaborative science, and the goal of the Alliance going forward is to promote and invest in your dreams. How can we push the boundaries for these rare but terribly deadly diseases? So look forward for your comments, your thoughts, and I want to thank all of you who joined today. We had 250 registrants from 25 countries. This is truly the power of collaboration. I hope you all have a wonderful Saturday, and thank you again for joining us for the 6th GenTAC Alliance Summit meeting.